जी अच्छा, आपने सैनिटाइजर रखा हुआ है, मैं लेके आई, मैंने कहा कुछ टच करवा दिया। चलो गुड, सैनिटाइज्ड है ना सब कुछ, कोई टेंशन की बात है?
कोई नहीं आया।
अच्छा नहीं, हाँ लेकिन वो थोड़ा तो होता ही है ना। पानी की बोतल, अच्छा अब मेरे ना दो चीज़ें हैं, एक तो पीपीटी है, दूसरा वो है वीडियोस हैं जो मुझे प्ले करने हैं, वो अलग फाइल्स हैं, तो सारे डेस्कटॉप पे ले लूँ? जब मैं स्टार्ट करूँगी तो मास्क उतार दूँगी, अभी पहना हुआ है। मेरे को तो सांस चढ़ने लगता है मास्क पहन के ज़्यादा देर ना, पर जब सब दूर हो जाते हैं ना तो फिर मास्क उतार देती हूँ मैं। हाँ जी बताओ, पहले बता दो आप।
कुछ नहीं, पहले आप अपना वो डालिए।
हाँ इससे डाल दो आप, इसमें भी है, मैं बता दूँगी। ये भी सैनिटाइज है ना, और अप डाउन इससे कर सकते हैं ना, मेरे को स्लाइड आगे पीछे करनी हो तो। और शेयर स्क्रीन कहाँ से करनी होती है?
मैं कर देता हूँ।
नहीं मैंने किया हुआ है, सिर्फ भूल गया एक्चुअली। हमने ली थी कब हुए थे, अप्रैल के बाद हुए थे ना, मई जून जुलाई, उसके बाद लंबा गैप आ गया है, तो बड़े गैप के बाद है ना, तो इतना हम यूज टू नहीं है, रेगुलर नहीं करते ना। अच्छा ये आपने डाल दिया है ना, तो अब मेरे को क्या करना है?
उसमें
अपने आप आएगा,
उसमें भी खोल सकते हैं आप,
पीसी से भी खोल सकते हैं। हाँ ये डीवीडी चला है ना। हाँ तो अब मेरे को इसको लेना है, 1 मिनट पहले लेना है लोकोमोटर सिस्टम 1, आज का लोकोमोटर सिस्टम 1 है, और 2 वीडियोस जो लेने हैं।
कर लो, कॉपी कर लो।
हाँ 1 मिनट, डेस्कटॉप से ही करना है ना? हो गया, अब करूँ आगे?
आप दूसरा वाला कर सकते हो।
वीडियो 1 एंड वीडियो 2, एक थोड़ा क्लियर ज़्यादा है और दूसरे में 1-2 चीज़ें हैं जो पहले वाले में नहीं है। सो दिस इज़ इट। क्योंकि सर ने सुबह उससे लिया ना, मैं तो ऑनलाइन थी, मैंने देखा था, वो अपने ऑफिस से ले लेते हैं ना। हाँ वो ना सर ने कंप्यूटर पता है ना सर को, हम लोग इतने टेक सेवी नहीं है, इसलिए मैंने कहा पहले LT2 से ही लेते हैं, वो बेटर रहेगा।
डॉक्टर राजी कहते हैं कि इससे करोगे तो अपना भी ट्रेंड हो जाओगे। हमें कौन सा आता है मैडम, हमें भी नहीं आता।
हाँ वही। अच्छा अब ये मैं रिजेक्ट कर देती हूँ और फिर ये डेस्कटॉप का देखती हूँ, चेक कर देती हूँ। आप तो बहुत दिनों से ले रहे हो, क्योंकि बाकी प्रोफ्स के तो चल रहे थे ना।
हाँ,
हमारे वो फर्स्ट, हाँ हमारे जो सेकंड सेमेस्टर था वो ख़त्म हुआ, फिर उसके बाद कोई क्लास ही नहीं हुई, फिर अब नए बैच के साथ स्टार्ट हो रही है। चलो अभी फ़िलहाल मैं यहाँ रख रही हूँ। अच्छा
उसमें भी हुआ ना पीपीटी?
अब वो नहीं, अलग नहीं है, मैं पेन ड्राइव इसलिए नहीं डाला, इसमें कई बार वायरस आ जाता है ना, तो इसमें हो गया डन। ये तो बैकअप के लिए लाई थी। अभी ना मैं थोड़ी घबराई हुई हूँ आज नहीं तो यहाँ खड़े हुए और बोला, कभी सोचा ही नहीं, तो थोड़ा सा ना मैं बैकअप सब कुछ लेके आई हूँ कि कहीं। अच्छा अब जब मैं शुरू करूँगी तो ये जैसे पीपीटी ऑन करूँगी तो पीपीटी बंद करके फिर वीडियो चलाऊँ?
हाँ
क्योंकि
मिनिमाइज
करके, हाँ करेक्ट, मिनिमाइज करके। और शेयर स्क्रीन कहाँ से करते हैं?
अभी तो मैंने किया नहीं, अभी टाइम है ना 15 मिनट्स है, अगर वो
अभी 15 मिनट्स है। हाँ ये कौन है लोग?
ये अभी बच्चे आए हैं अभी इस पे।
अच्छा मेरा आवाज़ तो नहीं जा रही उनको?
नहीं मैंने
ऑफ किया हुआ है ना, म्यूट किया हुआ है ना, अभी सिर्फ वो देख रहे हैं क्या हो रहा है। हाँ ठीक
नहीं आवाज़ जाता ना।
हाँ
कभी मेरे फ़ोन पे भी आवाज़ आता आपका।
हाँ राइट,
मैंने इसलिए बंद किया हुआ।
हाँ ठीक। मतलब म्यूट ऑल कर दो, जिसको क्वेश्चन पूछना है
नहीं
वो अनम्यूट करके अपने आप कर सकते हैं, क्योंकि
नहीं,
ऑनलाइन मीटिंग्स तो हो रही हैं।
हम इसको वो स्क्रीन शेयर कर देंगे, यो कर देंगे, ऑन कर देंगे, तो उनको जो पूछना हो आपसे पूछ लेते हैं, आप बात कर सकते हैं।
ठीक है
तो अभी 15 मिनट है इसलिए मैंने किया नहीं मगर।
हाँ ठीक है, 5 मिनट और रुक जाते हैं। सैनिटाइज
तो सर ने पहले बोला ना कि इसको 15 मिनट पहले करना पड़ता है।
हाँ
तो मैं इसको 20 मिनट पहले चालू कर देता हूँ।
हाँ कभी
वो कह रहे कि सर ये लॉगिंग होने में थोड़ा टाइम लेता है।
हाँ पुराने सिस्टम्स है ना।
सुबह नहीं, ये तो वैसे इनको तार का सिस्टम दूसरा लगा है, ये तो नया सिस्टम था मेरी।
ये तो नया है, हाँ ये भी नया है ना। और इवन दिस वेबकैम इज़ न्यू। ऐसे सीधे आएगा ना।
हाँ।
नहीं मेरे को सिर्फ ये बताओ शेयर स्क्रीन कहाँ से करते हैं, मैं भूल गई हूँ। मैंने किया तो हुआ है पर कहाँ से करते हैं ये बताओ।
ये ना अगर इसको मैं करूँ ना, ये स्क्रीन वाला ये है।
हाँ
इसको क्लिक करूँगा
हाँ
तो शेयर का आ जाएगा, लिख के वो शेयर का ये करके
हाँ।
शेयर करके हो
और
जाएगा।
मेरा वीडियो छोटा सा दिख जाए, बेशक बड़ा नहीं चाहिए मुझे, पीपीटी में चाहिए।
पीपीटी दिखाई देगा आपको यहाँ पे।
हाँ लेकिन मेरे को अपना वीडियो शुरुआत में दिखाना है, वो सर ने किया है।
वो वहाँ पे उनको दिखेगा।
हाँ छोटा सा,
हाँ
छोटे से बॉक्स में। ठीक है मेरे को बड़ा नहीं
जैसे
चाहिए।
मैं अपने फ़ोन पे दिखा दूँगा आपको, आपका वीडियो उनको दिखेगा।
हाँ छोटे बॉक्स में
हाँ।
है ना। हाँ हाँ मेन पीपीटी पे होना चाहिए, बिकॉज मैंने एक्सप्लेन इसके ऊपर करना है। और माउस को यूज़ करके पॉइंट करूँगी।
माउस को कर लो।
वो दिखेगा ना।
हाँ हाँ सब
ये
दिखेगा,
पॉइंटर
सब।
दिखेगा ना। हाँ
ये अभी भी दिख रहा है। यहाँ
हाँ देखो अब मैं इसे घुमा रही हूँ, दिखाना ज़रा अपने मोबाइल पे आपने लॉगिन किया हुआ है। अच्छा मेरे को लॉगिन आईडी बताओ किस। अच्छा मैं मोबाइल ही नहीं लाई, वो इसलिए क्योंकि बार बार ना।
ये देखो आप कर रहे हो ना ये।
हाँ अब इसमें प्रेजेंटर तो यही वाला है ना।
अभी
अच्छा
हम ये
अच्छा।
नहीं पे
अगर आप बनाओगे तो मैं कैसे लॉगिन करूँगी।
वो इसमें ना
हाँ।
यहाँ से करना पड़ता हमें, इससे यहाँ से क्लिक करके।
हाँ
फिर जो
मतलब मैं गो टू मीटिंग की आईडी से ज्वाइन करूँगी,
हाँ,
आप
हाँ,
मुझे प्रेजेंटर बना
हाँ
दोगे।
हाँ
ये कर सकते हैं।
हाँ
इमरजेंसी के लिए पूछ रही
हाँ
हूँ।
हाँ कोई वो तो आपको मेल पे भेजा होगा आईडी जो है ना।
हाँ वो मेरे को मिल गया, उसी से तो सर के उसमें लॉगिन किया
सबको
था ना।
जितने भी फैकल्टी सबको मेल आईडी भेजोगे।
हाँ। अच्छा यहाँ पे मेरी फोटो नहीं दिखाई देगी
नहीं,
जो मैंने
इसमें-
सेट फिस। अच्छा वो एक बार दिखा देना
वो
क्योंकि
सीटन दिखा दूंगा मैं।
हाँ अभी नहीं दिख रही।
हाँ
अभी वेबकैम ऑफ है। नहीं फर्स्ट टाइम जस्ट टू से गुड मॉर्निंग टू देम बिकॉज दे नीड टू रिलेट टू अ फेस, क्योंकि उन्होंने हमको देखा नहीं हुआ। सेकंड सेमेस्टर में तो मैं बिना कैमरा के किया क्योंकि वो देख चुके थे
आप
काफी
जब
कुछ।
इसमें करेंगे ना तो
हाँ।
आपका फेस भी आएगा इस पे।
हम्म।
ठीक है, बच्चे वो देख लेगा आपको।
तो शेयर स्क्रीन मुझे कहाँ से करनी है।
अभी पहले मैंने इसको ऑफ किया हुआ इन दोनों को।
हाँ इन दोनों को ऑन कर दूंगी।
हाँ ऑन करके
हाँ
फिर ये आ जाएगा स्क्रीन वाला, इसको ओके करेंगे ना
हाँ
तो फिर शेयर आएगा, शेयर को
और शेयर को ऑन कर देंगे। हाँ ऐसे ही करते थे फिर सिर्फ भूल गया है। पर ये बॉक्स कैसे खुला, ये बॉक्स कैसे खुला हुआ है।
ये हमने उससे खोला है,
किससे।
गो टू मीटिंग करते हैं उससे उससे खुलता है ये।
नहीं घर वाले कंप्यूटर से मैं लॉगिन तो कर लेती हूँ, टॉक भी कर लेती हूँ, कैमरा भी हो जाता है, वो मैंने किया हुआ
कुछ
है।
नहीं, उसमें स्क्रीन शेयर करना होता है बस।
हाँ
आपको
लेकिन
बस-
वो जो है ना
मैं आपको ना जैसे आप अपने घर से कर रहे हैं
मैं एक
तो
बार ये प्ले करके देख लूँ ये वीडियो चल रहे हैं कि नहीं। देखना चाहिए। आपके उस पर भी आ रहा है, आ रहा है ना।
जो भी इस पे चलेगा सब आएगा इस पे।
जस्ट टू चेक ये वीडियो चल रहे हैं कि नहीं। ठीक ये क्योंकि हमने अपने DH में बनाए हैं। और ये ऑफ कैसे करेंगे यहाँ से। अब ये सेकंड वीडियो है। अच्छा ठीक है दिख रहा है, मतलब सब कुछ दिख रहा है। सूचरल बॉन्ड्स ठीक है ठीक है। हाय तो अब इसको क्रॉस करने के लिए ये होगा है ना, ये वाला।
हाँ उसका हाथ लगेगा।
हाँ ठीक है। ये हो गया। और ये अपनी PPT ऑन कर लेती हूँ, लोकोमोटर। और इसका अच्छा जैसे अपने नहीं
अभी मैंने इसको रिकॉर्डिंग पे भी नहीं करा है।
रिकॉर्डिंग उसी वक्त करना। अच्छा आपने जब मेरे से बात की थी तो आपने स्टॉप रिकॉर्डिंग कर दी थी ना
यहाँ से हाँ,
जब मैं आपसे बात। हाँ जब आपने फ़ोन किया था मुझे।
फोन से इसके ऑफ करके इसको माउथ को फिर इससे ऑन करके इससे वो बात।
हाँ मतलब सर का जैसे लेक्चर खत्म हुआ आपने रिकॉर्डिंग ऑफ कर दी ना, क्योंकि मैं आई वॉज टॉकिंग टू यू थ्रू गो टू मीटिंग। मेरे को बाद में स्ट्राइक किया, ओह ये भी रिकॉर्ड हो रहा है। तो ये नहीं इसको हाँ अगर भेजना हो तो इसको क्रॉस कर दें। नहीं मिनिमाइज कर सकते हैं इसको, ये वाले बॉक्स को।
नहीं नहीं नहीं
मिनिमाइज नहीं कर सकते। नहीं तो फिर इसका स्क्रीन व्यू कैसे करें, ये PPT का मतलब वो स्लाइड शो आप करोगे वहाँ से। स्लाइड शो कैसे करें, स्लाइड शो कैसे करें। अच्छा इसको मिनिमाइज नहीं कर सकते
करना।
ये तो मिनिमाइज हो गया। अब ये कौन सा था, ये वाला ना, तो इसका स्लाइड शो का भी तो होता है ना व्यू। अच्छा व्यू स्लाइड शो से चले जाती हूँ। ओके ओके, यहाँ से चली जाऊँगी, ठीक है। नीचे से नॉर्मली करते हैं ना, व्यू स्लाइड शो में चले जाते हैं। अच्छा मतलब ये, हाँ
अभी तो मतलब ये है कि अभी आपका जो हम आपस में बात कर रहे हैं वो है, बस जब वो ये जब
एक बार सेटिंग कर देंगे ना तो मैं इसको क्रॉस करके बंद कर दूंगी ताकि मेरे को भी पूरी स्लाइड दिखे ना।
हाँ
या फिर मैं अपने, अच्छा मेरे को मतलब मोबाइल लाना पड़ेगा, मैं मोबाइल छोड़ा ही कि बीच बीच में फ़ोन ना आए।
हाँ ये दिक्कत होता है
हैं वो बहुत बार आता है ना, डिस्टर्ब करता है। नहीं तो इसको मिनिमाइज करने की कोई ऑप्शन नहीं है, ये होती होगी। हाँ ये है मिनिमाइज करने की ऑप्शन पूरा स्लाइड। अब ये देखो ना, हाँ दिस इज द वन। वो इज जस्ट अ क्वेश्चन ऑफ गेटिंग यूज टू, एक बार कर लो ना तो फिर आ ही जाता है। ये मिनिमाइज हो गया ना, पूरी स्लाइड दिख जाती है, और ये मैक्सिमाइज हो गया। हाँ।
ये तो वो ये कि मैंने भी कल ही किया है इसको फर्स्ट टाइम। वैसे तो मैं अपना ओबीसी
मतलब इसको ऑन करके वंस आई स्टार्ट, एंड इस घड़ी के हिसाब से स्टार्ट करेंगे ना, मेरी घड़ी तो पीछे है, मोबाइल की है ही नहीं।
तो ये है कि हमने भी कल ही मैंने फर्स्ट टाइम किया इसको।
अच्छा
तो मैं तो वैसे क्लास करा रहा था ऑनलाइन, जो क्लास यूट्यूब पे जो होता था।
वो कैसे करा रहे थे?
वो उसमें एक वो डाला हुआ है, इसमें ओबीएस डाला हुआ है, इसमें लिंक उसके थ्रू, मतलब ये अभी उससे के थ्रू चला हुआ है।
अच्छा अच्छा ओके। सो मैं इसको स्टार्ट योर रिकॉर्डिंग, ये क्रॉस किसके लिए है?
ये उसमें कुछ
लीव मीटिंग। अच्छा ये लीव मीटिंग का है, और ये क्या है? स्टॉप शेयरिंग स्क्रीन। अच्छा शेयर स्क्रीन ऑन है, सिर्फ मेरे को ऑडियो और वीडियो।
स्क्रीन भी अभी वो नहीं है, मैंने शेयर नहीं किया अभी।
अच्छा नहीं किया विद द अदर
शेयर करता ना तो मेरे
अटेंडीज।
स्टूडेंट दिखाई देते फिर यहाँ पे,
हाँ
इस
हाँ
पे ना
राइट।
फोन पे।
अच्छा जब ये हम ये करते हैं तो ये बच्चे भी चले जाते हैं ना। हाँ ठीक है ठीक है, ये उससे पता चल जाता है ना कितने अटेंड कर रहे हैं। अब जैसे आ रहे हैं ना 22 आ गए, अब ये इससे ये पता चल जाता है कौन कौन आए हैं। अब इसमें हमारे स्टूडेंट्स ये रहे।
ये मेरा दिखा रखा है।
अच्छा ये मनमोहन
हाँ,
आपका है,
अभी
श्वेता और अवन्ना, ये कौन है?
ये आपके डिपार्टमेंट के हैं।
नहीं पता नहीं ये कौन है। बाकी तो स्टूडेंट्स हैं अंडर ग्रेजुएट जो अभी
ये इसमें दिखा रहा है, जैसे हमारा एकेडमी सेक्शन दिखा रहा है ना, तो इससे मैं अभी मैं हूँ यहाँ पे, हमारा प्रेसिडेंट का हमारा। और जैसे आप अगर जो आप जुड़ेंगे इसमें
एकेडमिक सेक्शन से आ रहा है।
हाँ।
अच्छा अटेंडेंस वो लोग ही करेंगे, इधर से सीधे ले लेंगे।
हाँ,
हमको मेंटेन करने की ज़रूरत नहीं है, वही करेंगे। अच्छा मैं सुबह से ये सोच रही थी, बिकॉज इस सेमेस्टर के लिए ना मैं टीचिंग इंचार्ज हूँ, मैं सोच रही थी कि अटेंडेंस कैसे लें उसके अंदर से। ठीक है, मतलब वही करेंगे, वही कैलकुलेट करेंगे, हमारा कुछ है ही नहीं उसमें लेना देना। ठीक है, नहीं तो डिपार्टमेंट्स मेंटेन करते हैं ना। अच्छा तो ये मैं कर दिया, और ये चैट बॉक्स में जाके आई कैन सी वॉट एवर इफ़ दे पोस्ट एनी कमेंट। अच्छा और ये किसके लिए? स्लाइड, और ये सेटिंग्स के लिए। ये सारा सेट है, मैं उसको डिस्टर्ब नहीं करी, मैं जस्ट देख रही हूँ। अब ये नंबर जैसे बढ़ेगा ना, लाइक मॉर्निंग में थे 150 के करीब, 150 के करीब थे।
हाँ कुछ तो
है ना 150, और ये गो टू मीटिंग में
थे।
हाँ 150 के करीब थे, मेरे को एग्जैक्ट नंबर नहीं पता। और ये टोटल 251 तक अटेंड कर सकते हैं, तभी ऐसे लिखा हुआ है, समझ गई। तो अब ये मैं इसको ऑफ कर देती हूँ, तो ये दिखेंगे। अच्छा
आपको तो पता है मैडम, आपको क्या दिखना?
नहीं नहीं नहीं, बड़े दिन हो गए थे, मेरे को वो था इतने दिन से कर तो रही है ना, मैंने एक सेशन भी लिया था। जस्ट ये मेरे को ना मेरे घर वाले कंप्यूटर पे, घर मतलब ये कैंपस वाले और ऑफिस वाले कंप्यूटर पे ना गो टू मीटिंग का या ऑडियो नहीं खुलता या कुछ खुलता नहीं है, इसमें सब कुछ ऑपरेशनल है। तो मुझे लगा कहीं
इसमें से सब ये कैमरे से ही है सारा सब कुछ।
हाँ
तो कल 2 से 4 भी आपके रहेगा?
हाँ कल भी 2 से 4 है, कल कोई दिक्कत नहीं है, कल मैं पौने का हूँ। बट अभी ना मेरे को थोड़ा सा बड़े दिनों के गैप के बाद है ना, इसीलिए। बाकी जैसे अपना खड़े होके लेते थे वैसे बैठ के ले लिए। थोड़ा मैं डेमोन्स्ट्रेट भी करती हूँ। गुड आफ्टरनून सर, गुड आफ्टरनून, गुड आफ्टरनून। मैं भी जल्दी इसलिए आई हूँ, बड़े लंबे गैप के बाद
सर
कल सर का मॉर्निंग में
मेरा भी कॉल है।
ठीक है सर,
मुझे
हो जाएगा।
10 to 10
मैडम का करा दे तो आपको भी करा देंगे।
हाँ।
नहीं कोई खतरा तो नहीं
नहीं
है।
नहीं सर, कोई कहता
सर
नहीं।
वही तभी तो मैं आधा घंटा पहले आई हूँ, मुझे टेंशन हो गई कि कहीं ऐसा ना हो कुछ चले ना कुछ नहीं। सो आई टोल्ड हिम आई कम हाफ एन आवर अर्ली, कि वो बड़े लंबे गैप के बाद ले रही हूँ। तो सर आपका कल 10 to 12 है। हाँ
वो तो अगर सर दिक्कत आएगा
नहीं
ना सर-
क्वेश्चन पूछते हैं तो उसका वो इसमें आता है।
नहीं नहीं सब इसमें आएगा,
सब इसमें आएगा, इसमें कुछ
कल
नहीं
तो
आएगा।
मैंने देखा बोर्ड पे वो आ रहा था।
कल
अच्छा इसमें भी आएगा।
कल वो बायोकेमिस्ट्री वाला
हाँ,
था
हाँ,
वो।
हाँ।
अब उन्होंने क्या किया सर, वो प्रोजेक्टर पे लगवा दिया,
अच्छा अच्छा
लेकिन उससे सही तो मेरे को इस पे लगा, इसमें सही है ये।
वो तो सही है, लेकिन जैसे अभी हमारे रेजिडेंट्स कह रहे थे वो अटेंड करना चाहते हैं यहाँ दूर दूर बैठ के,
हाँ।
तो उनके लिए तो फिर बोर्ड चाहिए।
हाँ
तो हम ये प्रोजेक्टर लगा देंगे फिर।
तो लगा दो, पहले ही लगा दो बिफोर दे कम।
तो आ जाएंगे वो लोग।
कह रहे थे
आएंगे
कुछ
तो लगा देंगे।
स्टूडेंट्स, तो ठीक है तब इसमें कोई डिस्टर्बेंस तो नहीं होगी ना
नहीं
उससे?
नहीं नहीं
हाँ।
फिर आपको फिर वहीं से फिर वहाँ से कर, जैसे आप नॉर्मल करते थे ना,
हाँ
फिर वहीं से होगा, मतलब उधर दिखाई देगा आपको, इसमें कुछ दिखाई नहीं देगा।
फिर यहाँ नहीं दिखाई देगा?
सब उधर
नहीं नहीं फिर तो
साउंड
सर
सिस्टम तो
साउंड ये है। फिर आपको बैठ के ही क्लास लेना पड़ेगा यहाँ पे।
नहीं सर, फिर
तो
वो-
दिखाएंगे कैसे?
वो वहाँ पे दिखेंगे,
मतलब माउस
वो सब उधर दिखाएगा इस स्क्रीन से, क्योंकि स्क्रीन हटा दिया जाएगा ना, एक ही चीज चल
नहीं
सकता
नहीं
है।
अच्छा अच्छा दो नहीं
या तो
चलती,
इसको
फिर
चला
तो
सकते हैं।
यही बेटर है सर।
ये सबसे बेटर सर यही है,
नहीं ये तो बेटर है
क्योंकि
लेकिन
अगर स्टूडेंट को जो भी आपके वो है ना,
हाँ।
तो उनको आप उस पर वो कर सकते हैं।
अच्छा दे कैन लॉग इन,
हाँ हाँ हाँ
वो बेटर है।
अपना लैपटॉप अगर ले आएंगे
सब
तो-
सब
लैपटॉप
आपका-
क्यों, स्मार्टफोन पे कर लेंगे।
हाँ वो
हाँ।
तो
फोन पे करने की जरूरत
फोन
नहीं
पे,
है, बस
हाँ,
सीधा अपना
फोन
बैठ
पे
के
करो,
देखते
हाँ।
रहो, बस कुछ नहीं करना।
हाँ हाँ बोर्ड का
फोन पे
झंझट-
करेंगे सर, 47 है कम।
बोर्ड का झंझट बहुत खराब है।
हाँ मेरे को भी ना वो सर इतना आप रूटीन में आके अपना लेक्चर लिया और नो टेंशन। मेरे को आज थोड़ा सा हो रहा है कि है मीडियम में कुछ गड़बड़ हो गई,
अरे
तो वो बीच
इलेक्ट्रॉनिक
में
डिवाइस
देखो
सबको
अगर जो
डराता
इसमें
है।
वैसे भी
सबको-
दिक्कत
सबको
हो गई,
डराता है।
तो उसमें तो हम भी कुछ नहीं कर सकते।
हाँ
भाई नेट का कुछ फॉल्ट होगा तो
कभी-कभी
उसमें तो कोई कुछ
अमेरिका भी
नहीं
हिल
कर
जाता
सकता।
है।
हाँ वही तो।
नहीं तो बाकी तो ये चलता रहेगा।
तो इसीलिए मेरे को लगा घर में कोई डिस्टरबेंस हो गई, बेल बज गई, नहीं तो कैंपस में बैठ के भी मैंने ऑनलाइन किए हुए हैं डॉक्टर रेनू के साथ।
इसका वो सिस्टम बहुत अच्छा है।
हाँ सिस्टम
system
साउंड सिस्टम इज बेटर,
बहुत अच्छा
वही
है।
ना सर। तो वो
और हाई स्पीड इंटरनेट है जो घर पे नहीं है।
हाँ।
नहीं है, हाँ करेक्ट।
इसमें दूसरा वाला लगाया हुआ है, इन्होंने वैसा नेट नहीं लगाया, वैसे
हाँ
नहीं लगाया।
ऑर्डिनरी नेट नहीं है।
अब 57 आए हैं, वेट करूँ ना जब तक मेजोरिटी आ जाए।
हाँ हाँ
अच्छा तो कल आप रहेंगे इधर?
मैं तो 9:30 बजे आता हूँ
नहीं तो
सर।
मेरा पैन बच जाए।
हाँ
नहीं, नहीं, नहीं।
मैंने वही देखो डॉक्टर शरीफ की बात और है, वो ऑफिस से ले
वो
सकते
तो
हैं।
सब कुछ आता
He
है।
took from office, sir. I logged in today in the morning.
अच्छा।
From his office. But he is tech savvy, ना? He understands computers. उन्होंने पूरा इंस्टीट्यूट कंप्यूटराइज किया है। वो पता है उनको कि अगर कुछ प्रॉब्लम होती है हाउ टू फिक्स इट। हमें तो टेंशन हो जाए, हमें तो सब कुछ आता जाता भूल जाए। फ्रैंकली मैं नहीं कर सकती।
नहीं कल थोड़ा पहले फर्स्ट टाइम तो मेरे को भी अजीब सा लग रहा था, मैं
हाँ।
कहा यार मैं कर पाऊंगा नहीं कर पाऊंगा, नहीं तो
नहीं ये होते यूजर फ्रेंडली है,
हाँ,
बस
हमें तो इतना
फॉलो
इसका
करना
knowledge
पड़ता
भी
है।
नहीं है। मैंने मैं कहा देखा जाएगा
डॉक्टर
बाकी करूँगा।
शरीफ
नहीं
को
मेरा
नॉलेज है।
पिछले बार क्या हुआ था अप्रैल में वो माउस का वो नहीं हिला।
हाँ।
मैं पूरा पजल्ड हो गया।
हाँ
मैं पिक्चर कुछ दिखाना था मुझे माउस का वो-
मैंने मैं कहा देखा
हाँ,
जाएगा, फिर
देखा कि वो इंडिकेटर नहीं मूव कर रहा।
वो सर ने थोड़ा सा वो कर दिया ना, सर चाह रहे थे कि मैं इस पे भी देखूं और उस पे भी देखूं, मैं कहा उसमें हम फजल हो गए। अब मैंने मगर दो तो लगे ही नहीं, मगर सर एक ही चल सकता है, आप इसको चला लेंगे।
ये आप सर की बात कर रहे हो, डॉक्टर राह की?
डॉक्टर वो थे ना एचओडी थे बायोकेमिस्ट्री।
हाँ
अच्छा उनका
तो
काम-
उन्होंने शायद वो नीचे एकेडमिक सेक्शन में बोला भी होगा सर ने।
हाँ
ये फिर मैंने क्या किया ये काम नहीं कर रहा था।
हाँ
फिर मैंने लेक्चर में बताया कि ऑन दी लोअर राइट हैंड साइड ऑफ दिस पिक्चर कि वो नहीं काम कर रहा था। ऐसे ऐसे मैंने पूरा लेक्चर हो
माउस,
रहा।
हाँ
अभी
चलिए।
बच्चा जुड़ी रही
हाँ जुड़ रहे हैं, अब मैं स्टार्ट करने
और
लगी।
आप लोग नहीं थे उस टाइम, अगर आप होते मतलब अप्रैल में जब मेरा लेक्चर था वो हो जाता।
ये तो इसमें सर क्या अगर
मतलब
चलता
आप-
चलता कुछ हो जाता है।
कुछ हो गया था माउस का, तो मैं तो पैनिक हो गया। अभी माउस से दिखाना होता है। ओके तो आपका पक्का कोई
नहीं नहीं सर हमारी तरफ से आप बेफिक्र रहिए।
ठीक है थैंक यू। ओके मैडम
ओके सर, ऑल द बेस्ट फॉर टुमारो मॉर्निंग।
नाइस थैंक यू।
चलो अब आई थिंक आई शुड गेट ऑन, है ना?
इसको
नहीं मैं समझ गई, मैं कर लेती हूँ। अब आप सामने बैठ जाओ।
अब आप तो अब आपका तो ये हो गया।
हाँ नहीं, आप सामने बैठ जाओ, मैं मास्क उतार लेती हूँ और मैं शुरू करती हूँ, ठीक है? क्योंकि पहली बार स्टूडेंट्स को दिखना चाहिए। सर ने तभी तो उसमें से लिया ना, 99 तो आ ही गए हैं और 2 एग्जैक्ट बच गए हैं। अभी आप शेयर स्क्रीन वहाँ से करोगे ना?
नहीं
फिर
आपको उधर से करना पड़ेगा।
शेयर स्क्रीन तो हो रहा है, आपको तो आ रहा है। अच्छा मैं फिर पहन लेती हूँ, बताओ करो। फिर मैं कैमरा और वो ऑन कर दूँ?
हाँ फोन करो वहाँ से।
Unable to share webcam. It says. एको आ रही है ना, बिकॉज मैंने अनम्यूट किया। म्यूट कर दो। अब करो। ठीक है, ये तो स्टूडेंट्स आ गए, ठीक है 110 आ गए हैं। म्यूट ऑल रहने दो। इसको क्रॉस कर दो, स्टूडेंट्स चले जाएंगे। हाँ, या उसको क्लिक कर दो। हाँ, ये आपने क्या किया था? इसको बैक करो ज़रा। अच्छा आप उधर से कर रहे हो, ठीक है।
वो सभी तो सही।
नाउ शेयर स्क्रीन कैसे करते हो, ये तो पूछ रही हूँ। ये है ना स्क्रीन का। शेयर, यही तो, ऐसे तो होता है। एक मिनट रुको। गॉट इट। रुको, पीपीटी का मैं करती हूँ। ये तो कुछ नहीं करना ना इसको।
नहीं
क्लोज एंड नाउ व्यू स्लाइड शो। हाँ, नाउ इट्स कम। ये तो स्टूडेंट्स है, सम स्टूडेंट्स हैव शोन देयर वीडियो। नाउ टर्न ऑन द कैमरा एंड टर्न ऑन द दिस थिंग, है ना? अब आप सामने बैठो, मैं इसको वो कर लेती हूँ। अजय कुमावत हैज सेड गुड इवनिंग। ओके, अनेबल टू शेयर वेबकैम है। दिस इज अनेबल टू शेयर वेबकैम। वेबकैम नहीं शेयर हो रहा, स्क्रीन तो शेयर हो रही है। देन आई जस्ट टेक द क्लास, है ना? मैंने अभी म्यूट किया हुआ है अपने आप को। 127 हैव कम, पर वेबकैम नहीं शेयर हो रहा। वेबकैम क्यों नहीं शेयर हो रहा?
उसको करो ना, उसको स्क्रीन शेयर से करो ना। जो भी किया था, जो आ गया था ना कि स्टूडेंट आए तो।
नहीं समझ नहीं आया। एक बार इसको पॉइंट इससे कर लो। इसको करना जरा। हाँ, अब करो। क्या करना है? मतलब एक टाइम पे वेबकैम ऑन होगा तो स्क्रीन नहीं दिखेगी। वेबकैम तो ऑन नहीं हुआ, दे कांट सी मी। रिकॉर्डिंग ऑन कर देना जब वंस वी आर रेडी। वन स्टूडेंट हैज कम। ऑफ मत करो, मिनिमाइज करो। करना है तो ऑफ तो दोबारा से करना पड़ेगा। ये तो हो जाएगा, ये तो स्लाइड शो पे डाल दो तो स्लाइड शो पे आ जाएगा।
हमारा स्क्रीन नहीं दिखा रहा है।
वेबकैम नहीं दिख रहा। नेवर माइंड, आई विल जस्ट टेक द क्लास। वेबकैम का बाद में, मेरे को नहीं देख पाएंगे, दैट्स अबाउट इट। क्लास तो हो जाएगी ना। ये वेब कैम को ऑपरेशनल कर देना, ठीक है। आई टेल देम दिस।
देखना उसमें मेन तो वही है ना, उसमें
मेन तो यही है, लेकिन शेयर स्क्रीन का वो ऑप्शन का है। एंड शो से जाओगे,
1 मिनट लगेगा, ज़्यादा नहीं लगेगा।
इसको ऑफ मत करो, हाँ मिनिमाइज करो।
इसको कर देता हूँ मैं, 1 मिनट रुको बस।
इसको क्यों क्रॉस कर रहे हो, माइनस करो, आई मीन मिनिमाइज करो।
दूसरा वो करना पड़ेगा ना उसमें।
क्या क्या करना पड़ेगा?
ये दूसरे वाला यहाँ पे एक दूसरा आएगा ना, गो टू मीटिंग वाला।
अच्छा
एक मिनट, कोई नहीं,
कर लो,
1 मिनट लगेगा।
कर लो। Okay, I am ready. Mic, camera. ये स्टूडेंट्स चले क्यों गए?
दोबारा हो जाएगा।
They'll come in. This is a different ID या same ID?
नहीं सेम ही है, वो सेम।
So they are also logging in again. Now they are logging in. Okay, fine.
ठीक है ना।
मैं म्यूट करा है क्योंकि वो एको कर रहा था। आपको अपना म्यूट करना पड़ेगा, नहीं तो एको करेगा। नाउ द वेब कैम इज ऑल्सो ऑन। अच्छा, अब हाँ आपको ऑफ करना पड़ेगा। अब आ रहे हैं,
अभी चालू कर दिया आपका।
रिकॉर्ड कर दिया। रुको मैं कर देती हूँ। मैं पहले स्लाइड शो पे डाल दूँ ना। दिस हैज टू गो ऑन स्लाइड शो। करेक्ट,
ये रिकॉर्डिंग का ही तो
रिकॉर्डिंग का ना। Good afternoon, students. Can you hear me? Good afternoon, students. Can you hear me? Good afternoon. Am I visible to you? I don't know if I'm visible to you.
No, ma'am, you're not. No, ma'am.
Yeah, so the reason why we logged out initially was because the webcam isn't working in the LT2. Anyway, but the screen is visible, right? So we can take the class anyway. Maybe we'll have to wait to come face to face because there's some issue with the webcam. So I will begin because it's already time. How many of you have come? Let me see. 124 have joined. I think because I logged out, everyone logged out as well and rejoined. Is that so?
Yes, ma'am. Yes.
Yeah, I am Dr. Ritu Sehgal and I'll be taking the locomotor system in 2 lectures. Today 2 to 4 and tomorrow 2 to 4. The same time slot this week. Now normally we have a lot of demonstrations as well, but this time we don't have the advantage of seeing it right away, but maybe in a month or so we'll start the physical classes and then you can have a look at the real bones and the real cadavers. So for your batch it's postponed for a short while. I'm sorry about that, but that's how it is these days. The whole world is topsy-turvy. So has everyone arrived? Should I start or should I wait for more students to come? Should I wait? Okay, so I'll start. So today we'll be talking about...
This conference will now be recorded.
So today we'll be talking about the locomotor system. The musculoskeletal or the locomotor system consists of number of connective tissues, including the skeletal system, so the entire skeleton, as well as the muscles that act on those bones, right? So the movement of the whole body in space is known as locomotion, whereas the change in position of different parts of the body in space we refer to as movement or motion. So this is a slide which I normally project in my last lecture, which is on mechanism of walking. So just to relate it to your first lecture of gross anatomy, what exactly is locomotion? Locomotion is the movement of the body in space, and it requires a teamwork of muscles and joints. So the important things that you have to take away today, because this is an introductory lecture, is that in order for the whole body to move in space, what is required is coordinated muscle action, synchronization of the joints where the muscles meet, and normal functioning reflexes. So it's very important to have flexible and stable joints. The bones come together at meeting places called joints, and the muscles act across joints, and they have to move in a coordinated fashion. And all this is under the control of the nervous system, and so we require normal functioning reflexes. The components of the locomotor system are the skeletal system, the muscular system, and the action of the skeletal and the muscular system is under the control of the nervous system. So that will be taken up separately, but in the course of these two lectures, I'll be covering the bone and cartilage in today's lecture and the joints and muscles in the next lecture, which is tomorrow. Now, skeleton, which consists of bones and cartilages meeting at joints, they work together to bring about movement. And muscles act across joints. And all this is under the control of the brain, which uses information from diverse sources such as receptors in joints. These are known as proprioceptors, receptors in muscles, which are responsible for kinesthesia or muscle sense, and visual inputs from the eyes, and auditory inputs through the ears. Now, the components of the skeletal system are bone and cartilage, and the essential difference, they are both specialized connective tissues. The essential difference between bone and cartilage is that bone is a highly vascular connective tissue that is reinforced with calcium salts and various other traces of various other salts, and it also has bone cells, whereas cartilage is non-calcified and avascular. The term avascular means that there are no blood or lymphatic vessels which are actually present within the cartilage. But their general organization is similar. Both of them consist of a extracellular matrix or ground substance. Both of them have cells. The cells of the bone are known as osteocytes. Cells of cartilage are known as chondrocytes. And both have fibers, connective tissue fibers. And bones and cartilages of the skeletal system meet at junctional points which are known as joints, also known as articulations. So what is a joint? Joint is the junction or meeting place for two or more bones or cartilages. And if we did not have joints, if the whole skeleton was in the form of one rigid bone, what would not be possible would be relative movement of different parts of the body in space in relation to each other, and what would also not be possible would be the movement of the whole body in space, which we call as locomotion. I'm sorry, there seems to be a lag here. Yeah. Now bone, as I said, is a living vascular connective tissue which consists of a ground substance, which consists of fibers, and it consists of cells. All this together makes up the organic framework. And in this organic framework, inorganic salts, mainly the hard calcium phosphate, but also traces of other salts, are deposited in a well organized and characteristic manner. So we know that bone, despite its rigidity, is an extremely vascular living tissue because it is supplied, richly supplied by blood vessels, lymphatics and nerves. It has capacity for growth. It is subject to disease. So bones, they get thinner and weaker if we don't use them. For example, in a paralyzed limb, and they become thicker and stronger if we use them, if we exercise. So these terms relate to the increasing size and thickness and strength of the bones. When it becomes weaker, it is known as atrophy, and when it becomes thicker and stronger, it is known as hypertrophy. And the bone has a greater reparative capacity, refers to its capability of repairing itself than any other tissue in the body except for blood. So blood has the maximum reparative capacity, and the bone is second to blood in its capability of repairing itself. So it heals when it is fractured, and it also undergoes compensatory remodeling. It is able to withstand various types of stresses and strains, and unnecessary bone is resorbed. So from all these things we know that the bone is a living, highly vascular connective tissue. Despite its rigidity, it is not dead, it is a living tissue. Now if we go on to the composition of the bone, 1/3 of the bone is organic. We talked of the organic framework. The organic framework consists of dense white fibrous tissue and cells and fibers. So this is the ground substance, connective tissue, fibers and cells. And the inorganic part of the bone consists of the various types of salts, of minerals. So by weight, 1/3 is organic, whereas 2/3 is inorganic. The organic part is composed of white collagen fibers and cells which are known as osteocytes, whereas the inorganic part consists of calcium phosphate but also calcium carbonate and traces of calcium fluoride, chloride and magnesium salts. Now why does the bone have an organic framework and an inorganic component? The reason is these have specific functions. So the organic part of the bone gives it resilience and toughness, provides a framework so that the bone is able to withstand compressive forces during weight bearing, whereas the inorganic salts give it hardness and rigidity. And it is because of the inorganic salts, notably calcium phosphate, that the bones are opaque to X-rays. So when we look at an X-ray, we are able to appreciate the entire skeletal system because of the calcium content of the bones, the salts of calcium which are present in the bones. The bone is the hardest tissue in the body excepting the enamel of tooth. So the hardest substance in the body is tooth enamel, and second to that is bone. It has a specific gravity of 1.9, and we already saw in the last slide the hardness and rigidity of bone is due to its calcium content, salts of calcium. The bones are resistant to forces of compression, which means during jumping, running and weight bearing, which means during standing. They are also resistant to forces of tension, that is the pull of muscles, tendons and ligaments which are attached to the bones. And they are also resistant to twisting forces. And this tensile strength which is conferred on the bones is because of its organic framework. Some of the physical properties of the bone can be decalcified by immersing it in mineral acids like nitric acid, sulfuric acid, hydrochloric acid. So when we do that, the organic framework of the bone remains intact. In fact, the bone becomes so flexible that you can actually tie it up into a knot. And it also, the reason why we do it is when we do tissue processing in order to cut thin slices of bone so that we can view it under the microscope. So it is the organic framework which gives that flexibility and resistance to these kind of forces and makes it flexible. Whereas decomposition will lead to removal of the organic framework. Now this decomposition can be achieved by bacterial action when we bury the bones, or it can be achieved much faster by burning or incineration. So here the inorganic material will remain, whereas the organic material will be destroyed slowly by decomposition due to bacterial action, or fast as in burning. But these kind of bones are extremely brittle and they will crumble and fracture easily. If we subject bones to extreme dry heat, they will tend to undergo mummification and they will endure, they will be preserved for longer duration of time. Bones can also be preserved when they get inadvertently buried in soils or caves which are rich in limestone or in iron, lead or zinc. So in these conditions they become petrified, giving rise to formation of fossils. So in case of limestone, for example, the calcium carbonate will replace the organic matter in the bones. Now going on to the functions of the bone, most of these you already know. They form a rigid supporting framework to the body. They give shape to the body, support body weight and transmit it to the ground. They are responsible for us being able to maintain our upright posture, and it would be impossible without bones, without the vertebral column. When we talk about the spine here, we are referring to the backbone. Muscles are attached on bones and hence bones form levers for muscle action. Joints are where bones articulate, and because muscles act across joints, they make relative movement as well as locomotion possible. So bones are providing surface for the attachment of muscles, tendons, ligaments as well as condensed connective tissue layers which are known as fasciae, and various types of membranes. Now there are three general coverings in the body. The skin, the superficial fascia and the deep fascia. So these are the fasciae that we are referring to at the moment, right? So fasciae, these are condensed connective tissue membranes, and the other membranes would be, for example, interosseous membranes. The bones also provide protection to vital organs and viscera. Here I would like you to see, just a minute, the entire skeleton. So I have a video for you just to give context to what I am saying. Yeah. Now if we look at the skeleton, so you see the rib cage here, the skull houses the cranial cavity houses the brain. The rib cage houses the vital organs such as lungs and heart. The pelvis houses the lower abdominal and certain pelvic organs. So in this way they provide protection to vital organs, and this is the vertebral column which lodges the spinal cord. I will play this later. Yeah, going back to the right. So they provide protection for vital organs and viscera. For example, the brain and spinal cord are lodged in the skull. The heart and lungs are lodged in the thoracic cage. The liver, stomach and spleen are protected by the lower ribs, and the lower abdominal and pelvic organs are also known as viscera. So today is the day where you are learning a lot of new terms. It's an entirely different language. So it will take some time to get used to them, but don't worry about it. You'll learn by and by. So pelvic viscera are lodged within the bony pelvis. Bones are also the site because of the presence of the red bone marrow in the medullary cavity of long bones, and the yellow bone marrow in the medullary cavity of long bones, and the red bone marrow which is present in the cancellous bone or the spongy bone which is at the ends of long bones. And during fetal life, red bone marrow is present at both sides. So wherever you find red bone marrow, that is a site that belongs to the reticuloendothelial system, which is the site where formation of new blood cells takes place. So white blood corpuscles, red blood corpuscles and platelets all are formed at these reticuloendothelial sites. 95% of the calcium within the body and phosphorus is also stored in bones, and these minerals are extremely important for various activities within the body, particularly contraction of muscles. There are certain bones we will learn today which are called pneumatic bones, which have air cavities, and these air cavities also have important functions which we'll learn as we go to the next couple of slides. Bones also have immense anthropological and forensic significance. So when we look at bones, we are able to estimate the age of the individual, the gender of the individual. We can even calculate the height of the individual if we find remains, if we find the femur, the long bones like the femur and the humerus, the race can be estimated. And also in case of fossils, we can identify the species. So bones have a lot of significance, forensic and anthropological. Now coming to the main part of the class today, we will do the classification of bones. The bones can be classified in various ways. So one way of classifying bones is through the regional classification, depending on where in the skeleton they are present. So according to their location close to the central axis of the body, they are known as axial bones, and if they are farther away from the central axis of the body and form the girdles of the limbs, the upper limb and the lower limb, they are known as appendicular bones. So here if we look at this picture, so the skull, the vertebral column, the rib cage including the ribs and the sternum, these together form the axial skeleton, whereas the pectoral girdle consisting of the clavicle and the scapula, the pelvic girdle consisting of the hip bone on either side, and the bones of the free limbs, upper limb and lower limb. You can see here, these are known as appendicular bones. So these are appendicular bones, whereas these are axial bones. So this is one way of classifying the bones. Right? So axial bones and cartilages lie close to the central axis of the body, whereas the appendicular bones form the limbs, the upper limb and the lower limb. They are bilaterally symmetrical and consists of, in the case of the upper limb, the pectoral girdle with 2 clavicles and 2 scapulae. Clavicle is the collarbone, scapula is the shoulder blade. The free bones of the upper limb consists of, if we look at this picture, this is the humerus on either side. Let's identify the bones. The humerus on either side, the radius and ulna, radius being the lateral bone, ulna being the medial bone, radius and ulna. And then the bones of the wrist, which are known as the carpal bones, which are 8 bones arranged in 2 rows of 4 bones each. There are metacarpals, which are the bones of the hand proper, 5 each, and 14 phalanges making up the fingers and the thumb. For the lower limb, the pelvic girdle is made up of a hip bone on either side, and the free bones of the lower limb are the femora is plural, so femur on either side. This is the bone of the thigh. The tibia, which is the medial bone of the leg, the fibula, so on either side, these are bilaterally symmetrical. 7 bones in the tarsus, 5 metatarsals and 14 phalanges. The lower limb also has kneecaps, the patellae. Right, so these are the appendicular bones. And let's do the axial bones once again. The skull, the vertebral column. The vertebral column consists of 7 cervical, 12 thoracic, 5 lumbar, individual vertebrae, 1 fused mass which is known as sacrum, and 1 coccyx. The sacrum consists of 5 vertebrae which are fused together, and the coccyx consists of 4 coccygeal vertebrae which are fused together. There are 12 pairs of ribs, and there is a single sternum which is in 3 parts: the manubrium, the body and the xiphoid process. Right, so the skull itself has 22 bones. 8 of these form the cavity which lodges the brain, known as the cranium, and 14 form the facial skeleton. There are 3 ear ossicles on either side, and there is 1 bone at the junction of the floor of the mouth and the front of the neck, which is the hyoid bone. So these are all the bones in the body, making up a total of 206 bones. I hope it's clear. It's a little tough when I cannot see you people and you cannot see me, but I'm used to seeing the students and interacting with them, but we'll try to make the best of it. So in the adult skeleton, there are approximately 206 bones, but this number varies depending on the age, and also there are some people who have some extra bones. So there are individual bones, individual variations. Initially, the number of bones are more. So in a younger child or a growing child, the number of bones are more. This is because certain compound bones ossify from separate ossification centers, which later fuse to form one bone. So the number actually decreases as we grow older. So initially at birth it is 270, and it becomes, by adulthood, it becomes 206. Now bones can also be classified based on how they ossify. So there are 2 ways in which a bone can ossify. They can ossify in membrane, in mesenchymal membranes, and undergo what is known as intramembranous ossification, or in these mesenchymal membranes, there is a preformed cartilage model, and these bones undergo what is known as endochondral ossification, and these are therefore known as cartilage bones. So we can classify bones as membrane bones or cartilage bones. Membrane bones are present mostly in the bones of the cranial vault. That is, they form the lateral walls and the roof of the cranial cavity. Yeah. So the frontal bone and the parietals, the frontal and the parietal are examples of membrane bones in the skull. Right? And bones of the facial skeleton, zygomatic, maxilla, nasal bones. I'll show you as much as I can in the pictures. So the zygomatic, this is the maxilla, and these forming the bridge of the nose, these are the nasal bones. So nasal bones, this is the frontal bone, these are the parietal bones. All these ossify in membrane. The bones of the facial skeleton and the cranial vault. Vault means lateral walls and the roof. Whereas the bones of the cranial base as well as the limb bones, they ossify in preformed cartilage models. So these are also known as cartilage bones. So humerus, radius, ulna, femur, tibia, fibula, all these ossify in cartilage. So these are known as cartilage bones, right? The bones of the vertebral column also ossify in cartilage, and bones of the thoracic cage, that is the sternum and the ribs, also ossify in cartilage. Certain bones are partly ossified in membrane and partly in a preformed cartilage model. So these are known as membrano-cartilaginous bones. Examples of these are certain bones which are present partly in the cranial base and partly in the cranial vault. For example, the sphenoid bone, the temporal bones, the occipital bone, and the mandible. Now let's identify this in the diagram. Now this is the temporal bone. This is a part of the sphenoid bone. This is the mandible. These and one other bone which ossifies both in membrane and cartilage is the clavicle, the collarbone. The medial end ossifying in cartilage, most of the bone ossifying in membrane. So these are known as membrano-cartilaginous bones. Is it clear so far? Then I'll go.
How membrane bones develop, that I didn't get.
That you learn by and by, but you know, in embryological development, there is the embryonic connective tissue is known as mesenchyme, and that mesenchyme condenses to form a membrane, and the ossification happens directly in the membrane. Those kind of bones are known as membrane bones, whereas in cartilage bones, within that condensed membrane, there is first the formation of a cartilage model, and then the ossification centers appear which form the bones. Those type of bones are known as cartilage bones. You will do ossification in detail in embryology as well as histology, in both. Okay? So right now we are, as from the point of view of general anatomy, just introducing to you these terms. Okay?
Ma'am,
Yes.
in cartilaginous bones,
Yes.
You said that some bones at the base of the skull are cartilaginous. So,
Yeah.
which one?
So I can't show you in a picture, so I wouldn't like to say right now, but there are bones, for example, the ethmoid,
Yes, ma'am.
and basilar part of the occipital. Occipital actually, the squamous part ossifies in membrane and the basilar part ossifies in cartilage. Similarly, for the temporal bone, the part of the bone which forms the cranial base ossifies in cartilage, whereas the part which appears in the lateral wall of the skull ossifies in membrane. For sphenoid, it is the same thing. The part which, the greater wing of sphenoid ossifies in membrane, but the part which is forming the cranial base in the center, that ossifies in cartilage. But there are some bones which ossify entirely in cartilage, like the vomer, the ethmoid, they ossify in cartilage, like that. Okay?
Thank you.
We are not getting without pictures.
Yeah, I know that. I'll project the pictures. Just give me some time. Now we can also classify bones based on their shape. So based on their shape, bones can be classified into long bones, short bones, flat bones, irregular bones, pneumatic bones, sesamoid bones, and there is one other category which are known as supernumerary or accessory bones. So let's take it one by one, starting with the long bones. And you said you wanted pictures. Okay. So the bones of the free upper limb are long bones. So in long bones we include, this is the humerus, the ulna, the radius, this is the femur, this is the tibia, this is the fibula. All these are long bones, right? They are cylindrical or tubular in shape. They are not exactly cylindrical, actually they are triangular in section. Now if we look at the hand here, this is the carpus, the bones of the wrist. This is the metacarpus consisting of 5 metacarpal bones, and these are the phalanges. There are 2 phalanges for the thumb and 3 for each of the fingers which are medial to the thumb. Now here in the lower limb, this is the tarsus consisting of 7 bones, the metatarsus again 5, and there are 14 phalanges. The big toe is medial, whereas the remaining toes are lateral to it, right? So 3 in each of these and 2 in the big toe. Now these are also long bones, but they are, because of their small size, they are known as miniature long bones, right? So whereas these are called long bones, the metacarpals, metatarsals and phalanges are known as miniature long bones. Fine. So long bones are clear. Which ones are long bones? Right? Now we go on to the next category, which is short bones, which are more or less cubical in form. So the bones of the carpus and the tarsus. These are the carpals and the tarsal bones. These are more or less cubical in form. These are known as short bones. Okay? And then we have flat bones. Now here in flat bones we would include those bones which form lateral walls of cavities. So among the flat bones we include the scapula and the ribs, because they define the lateral walls of bony cavities, isn't it? So they are flat in shape. I will project the video for you, then you can have a look. Just a minute. Can you see the video now? Now all these bones are in a tray. This is actually recorded from our dissection hall. Normally you get a demo. So this is a long bone. It consists of a shaft and 2 ends which are flared up. This is the humerus. Now this is an articulated hand. Here you can see these are the carpals, and you can also see the metacarpals, and these are the phalanges. These would be included in miniature long bones. Now here you can see a vertebra and the hip bone. These are known as irregular bones because they don't subscribe to any well-defined shape which we can call as long or short or flat. Although parts of irregular bones may be flattened. So vertebrae we include in irregular bone. Now this is the shoulder blade or the scapula. Now this is usually classified as a flat bone, although we can call it an irregular bone as well. This is the maxilla. Now this has a bony cavity, so it is known as a pneumatic bone. This is the kneecap or patella. This is a bony nodule which is formed in the tendon of the muscle of the thigh, which is called quadriceps femoris. So it is known as a sesamoid bone. And this is the skeleton to place it in perspective. So we see various, so these are all long bones on either side, miniature long bones, long bones, long bones. Hip bone is irregular. Vertebrae of the vertebral column irregular. Ribs are classified as flat bones. The scapulae are classified as flat bones. You have flat bones in the cranial vault. You have irregular bones in the base of the skull. So these are based on shape. And now I'll end the video and go back to the PPT. Yeah, sorry. Now once you've seen all the bones, I hope you can understand that long bones are tubular weight-bearing limb bones which serve as levers for muscles. Miniature long bones would include the metacarpals, metatarsals and phalanges. Long bones, whether they are the longer variety or the miniature variety, usually subscribe to a particular shape. They are all vertical, they are hollow and they ossify in cartilage. They consist of a main part which is called the shaft or the body, which has a cavity known as the marrow cavity or medullary cavity, and they are triangular in section. They have 3 surfaces and 3 borders. Their 2 ends are enlarged and these ends will have spongy bone and are covered with articular cartilage. Have you understood long bones? Which ones are the long bones? The details I'll do in the subsequent slides. Have you understood?
Ma'am,
Yes.
what are the 3 surfaces and the 3 borders?
I will do that. Have you understood which bones are the long bones?
Yes, ma'am.
Okay. Then short bones are cubical. These ossify in cartilage after birth, except certain short bones like the talus, calcaneus and cuboid. These are some of the tarsals. They mainly consist of spongy bone covered by a thin shell of compact bone. And these are confined to the carpus and the tarsus. Flat bones are curved plates which form the walls of cavities. They consist of spongy or cancellous bone that has red bone marrow sandwiched between 2 plates of compact bone. And here in flat bones we include bones of the cranial vault, sternum is another example, scapulae, ribs and certain parts of other bones like the ilium part of the hip bone is flat. Similarly, parts of sphenoid are flat, parts of occipital bone are flat and others are irregular. Irregular bones are irregular in shape. They consist of spongy or cancellous bone covered by a thin shell of compact bone. And we find them in the cranial base, in the vertebrae and in the hip bone. Pneumatic bones are bones which have air cavities within them. They are formed by the expansion of the nasal mucosa and the ear mucosa into flat or irregular bones. And the reason why these are present is to lighten the weight of the skull, to add resonance to the voice, to humidify the air. But the disadvantage of having pneumatic bones in the skull is that they are sites of infection. So many of you may be suffering from sinusitis. So sinusitis is because air sinuses are present in some of the skull bones like maxilla, sphenoid, ethmoid, frontal, and also in the mastoid process of the temporal bone. These are the ear ossicles. So bones of the cranial vault, vertebral column. This is the rib. This is the sternum. These are the vertebrae and how they articulate with each other. These are the ribs. And this is an individual vertebra. Now, you asked about the different parts and how are the surfaces and borders of a long bone. So this picture shows you a long bone. This is the humerus, the posterior aspect of the humerus. This is the anterior aspect of the femur. This is the bone of the arm, and this is the bone of the thigh. As you can see, although they are tubular in form, they are not actually cylindrical. They are normally triangular in section. So if we take a section through a long bone, it would be triangular like this. So it usually has 3 surfaces and 3 borders. So this is the anterior border, medial border, and lateral border of the humerus. Similarly, for the femur, this is the medial border, lateral border, and posterior border of the femur. And this cavity that you can see in the central part, this is known as the marrow cavity or the medullary cavity. So a long bone is constructed in the form of a hollow tube with 2 ends, a proximal end and a distal end. So this is the proximal end and this is the distal end of both these bones. The end which is closer to the trunk is called the proximal end, and the end which is farther away from the trunk is the distal end. Fine. The medullary cavity contains yellow bone marrow in long bones, in adult long bones. So initially the medullary cavity at the time of birth contains red bone marrow, but by about 7 years of age, this starts to be replaced by yellow marrow, so that by 18 years of age, it is entirely composed of yellow marrow, the medullary cavities. The ends of the long bones actually consists of spongy or cancellous bone, and these are surrounded by a thin shell of compact bone. It is here that you will find red bone marrow after 18 years of age, because it has receded from the medullary cavity. The articular ends, the ends of the long bones which form joints, these are covered by articular cartilage. So you can see this smooth cartilage that you can see here, this is known as articular cartilage. And the shaft of the long bone is covered by a layer of connective tissue which is known as periosteum. So the periosteum surrounds the entire bone except at the ends which are covered by the articular cartilage. And the marrow cavity is lined by endosteum. Is that clear? Now is it clear? How does it have borders and surfaces? So this is how long bones are formed. Even the miniature long bones, the metacarpals and the metatarsals and the phalanges have roughly the same kind of form. So although they may be appearing here unless you see the actual bone. They may be appearing to be cylindrical, they are not. They have 3 borders and 3 surfaces. Is it clear now? Now we will do the parts of the immature bone. Now we said that the mature bone consists of a shaft and 2 ends. But in a young or an immature bone, the terminology is different. Bones ossify from ossification centers. So if there is an ossification center which appears first and forms the main part of the bone, that ossification center is referred to as the primary center of ossification. The primary center of ossification is that center which either appears in the membrane or in the preformed cartilage model and forms the major part of the bone. And this is the center which appears first in the bone, usually during intrauterine life. In the general rule is it appears during intrauterine life. There are some exceptions, but the general rule is it appears approximately at 8 weeks of intrauterine life, right? So the part of the long bone which is ossified from the primary center of ossification is known as the diaphysis. The part of the long bone which is ossified from the primary center of ossification is known as the diaphysis. The part of the long bone which ossifies from a secondary center of ossification, which forms the ends of a long bone, is known as epiphysis. And the epiphyseal end, the flared out epiphyseal end of the long bone is known as metaphysis. But please remember, these terms will relate to only the immature or the young bone. Now at the junction of the diaphysis and the junction of the diaphysis, this is diaphysis, and the epiphysis is an epiphyseal plate of cartilage which will persist as long as the linear growth of the long bone is going on. So till the time the increase in height of the individual goes on, the epiphyseal plate of cartilage will persist. Okay, because this is the site where new bone is forming at the ends of the diaphysis, which is why we give a different term to the epiphyseal end of the diaphysis. We call it the metaphysis. Okay. So the ossification is the process of formation of bone in an organized fashion. It is not just calcification. Ossification refers to laying down of bony lamellae in an organized fashion, and these lamellae will consist of connective tissue fibers, it will consist of cells, it will also consist of the inorganic calcium salts. And this ossification proceeds from primary centers which appear before birth, and after birth at the ends will appear the secondary centers. And the part which ossifies from the primary center is known as diaphysis, whereas the part which ossifies from the secondary center is known as epiphysis. So far, is it clear? Any questions? Yes.
Ma'am, in a mature bone, can we identify the junction of diaphysis and epiphysis?
We know where it is present. An epiphyseal line will be present at the junction of the diaphysis and the epiphysis. That will tell us that the epiphysis has fused with the diaphysis, and what will persist will not be the epiphyseal plate of cartilage but a line
to indicate it. But ultimately, as you grow older, even the line will be obliterated. So when the fusion is recent, we can see the epiphyseal line. As you grow older, in your 30s, 40s, the epiphyseal line will also be obliterated. But we know the location. And we will be doing it, studying it in each bone. Okay? Have you understood what is metaphysis?
Yes, ma'am.
Has everyone understood? So this part is metaphysis of the humerus. This part is the metaphysis of the lower end of humerus. This is at the upper end, this is at the lower end. Similarly, this part is the metaphysis of the femur at the proximal end, and this is the metaphysis of the femur at the distal end. In other words, upper end and lower end. So metaphysis, in other words, is the flared out part of diaphysis. It's not a separate part, it's a part of the diaphysis. Clear? Whereas epiphysis is separate, the end which ossifies from the secondary center. Metaphysis and the rest of the diaphysis ossifies from the primary center. Okay? Now, these centers of ossification appear after birth at the ends of long bones, with some exceptions. Now, bones such as the humerus and femur have two ends. So, the ossification centers will appear at both the ends. But out of these two, there will always be an end which appears first and an end which appears later. Right? Now, there is a law of ossification which states that the ossification center which appears first is the last to fuse. And because of that, the appositional growth of the long bone will proceed longest at that end. So that end of the long bone is known as the growing end of the long bone. In other words, the upper end, the ossification centers which ossify the upper end of the humerus, and the ossification centers which ossify the upper end of the femur. You know, and there are ossification centers which ossify the lower end of the humerus and of the femur. So in the case of the humerus, which is the bone of the upper limb of the arm, the ossification centers for the proximal end appear first and fuse later. Whereas in the case of the femur, the secondary ossification centers for the lower end of the femur will appear first and fuse later. So the linear growth of the humerus will take place for a longer duration of time and to a greater extent at the proximal end, whereas for the femur, the same will happen at the lower end. So for the humerus, the proximal end is the growing end, whereas for the femur, the distal end is the growing end. So of the two ends of a long bone, one is known as the growing end. And the growing end is usually that end of the long bone where the secondary ossification center, which has formed the epiphysis, has appeared first and fused later. And that is what is known as the law of ossification.
But epiphyseal plate is present on both ends, so
Yes.
why does it grow only from
Epiphyseal plate is present on both ends. But the center which appears first fuses later, so the linear growth will occur for a longer period of time at that end. Because it's the way genetically certain parts of the skeleton are programmed. The ossification centers appear at specific ages and they fuse at specific ages. So for each bone, there is a growing end. For a bone where there is ossification center at only one end, the growing end will be that end. But in bones where ossification centers are present at both ends, the law of ossification states that the end where the ossification center appears first fuses later, and therefore that end is the growing end. Okay? These are a lot of terms. Normally we have the advantage of actual bones being demonstrated to you. We don't have that advantage, so it's a little difficult to explain, but I'll try to make the best of it. Anything you don't understand, please ask. Now these epiphyses are of various types. There are certain epiphyses which are present in the line of weight bearing. For example, if we look at the entire skeleton, the weight of the body is transmitted from the skull along the vertebral column, and then from the vertebral column through the two hip bones, through the hip joint to the to the femora on both sides, then to the tibia, and then to the feet. And for the upper limb also, the weight of the upper limb is transferred to the axial skeleton via the collarbone. So there are parts of these long bones in the limbs which are weight bearing. So for the upper limb, the weight bearing parts are the head of the humerus, the lower end of humerus, the upper end of ulna, the lower end of radius, the carpus, and the bones of the hand. For the lower limb, the weight bearing is done by the upper end of the femur, the lower end of the femur, the upper end of the tibia, not fibula, and then lower down by both tibia and fibula into the tarsus and then the foot. So wherever you have parts of the long bone which are weight bearing, those epiphyses are known as pressure epiphyses. So the head of the humerus, the head of the femur are examples of pressure epiphyses. Right? Upper end of tibia is also an example of pressure epiphyses. This is known as the condyle of the tibia. Okay? These are pressure epiphyses. However, both the humerus and the femur also have these elevations. Can you see this? This is known as the greater tubercle of the humerus, the lesser tubercle of the humerus. Similarly, in the femur, this is the greater trochanter, this is the lesser trochanter. Okay, right? So these bony prominences give attachment to muscles and tendons. And these are also ossified from separate ossification centers, but because they give attachment to tendons, they are known as traction epiphyses because they are subject to the pull of tendons. Then there are certain epiphyses which are initially phylogenetically separate bones, but in humans have fused to a neighboring larger bone. For example, if we look at the scapula, we have the coracoid process. So the coracoid process phylogenetically is a separate bone which has fused to the scapula in the vicinity. So this ossifies from a separate ossification center, and this is known as atavistic epiphyses. And at certain sites there are extra epiphyseal centers which are present in some individuals only, and those are known as aberrant epiphyses. So there are 4 types of epiphyses. pressure epiphysis, traction epiphysis, atavistic epiphysis and aberrant epiphysis. Now, just to get a perspective of centers of ossification. So, this is a picture of the humerus, right? So, here you can see this is a primary ossification center. This is how initially cartilage bones ossify. That in the condensed mesenchyme, a cartilage model is formed, and in that cartilage model, a focus appears where the cartilage starts to get replaced by bone, and that focus is known as the ossification center. And the ossification center, which gives rise to the main part of the bone, forms the shaft of long bones, is known as the primary ossification center. Have you understood now? So this is how it proceeds, ossification of long bones. During development, during intra-ut, so this will create a kind of woven bone which is not yet able to withstand the stresses and strains. The periosteum, which lines the shaft of the bone, then starts to lay down more dense bone, which is known as compact bone, forming what is known as a periosteal collar, and this periosteal collar will subsequently form the shaft of the bone, and this cancellous bone will get resorbed by bone resorbing cells which are known as osteoclasts. So this is how ossification happens and is subject to several factors: mechanical, genetic, nutritional and hormonal, which is why vitamin C deficiency leading to scurvy, D deficiency leading to rickets will interfere in this process. Now, for your question, the epiphyseal plate of cartilage is present at both ends, and there are zones of ossification: a proliferating zone, a hypertrophy zone, a zone of calcification. So this is proceeding from this side in the metaphysis and from this side in the epiphysis. And until the time this plate of cartilage persists, the linear growth of the long bone will happen. Once the epiphysis fuses with the main part of the bone, diaphysis, the length of the long bone will not be increased anymore. Now this is genetically programmed at what age this happens. Have you understood? So at one end, the growing end, the fusion will happen later than at the other end. That is the non-growing end. Right? Now if you see here, each of the long bones have a nutrient foramen, and the artery which supplies the marrow cavity of a long bone is known as the nutrient artery. Initially, the nutrient artery goes transversely into the shaft of the bone through a nutrient foramen. Okay? But because more bone is added later from one end compared to the other, this nutrient foramen, which was initially transverse, becomes oblique and starts to point away from the growing end. So the growing end of a long bone can be deduced by looking at the nutrient foramen in the long bone, the direction in which it points. So the nutrient foramen in the long bones of the upper limb point towards the elbow. Therefore, the growing end of upper limb bones are at the other ends. So if we look at the upper end, I know I am explaining, I know you have a lot of questions. The nutrient foramen of the humerus will point towards the elbow, of the radius will point towards the elbow, the ulna will also point towards the elbow. From that you can know that the growing end of the humerus is its upper end, and of the radius and the ulna are their lower ends. Whereas in the lower limb, the nutrient foramina point away from the knee. So the lower end of the femur is the growing end, the upper end of the tibia and the fibula are their growing ends. And the mnemonic to remember this direction of the nutrient foramina is to the elbow I go, from the knee I flee. This is something we have deduced by studying the bones. The nutrient foramina of long bones point away from the growing end. Now the question. Now ask your question. Somebody had a question?
No, ma'am.
Is it answered?
Yes, ma'am.
Okay. So this is the artery
Why
which
the nutrient foramina?
yeah.
Ma'am, why the nutrient foramina point away from the growing end?
Because more length of bone is, see, initially it is transverse because bone is being added from both ends. But then the epiphysis of one end will fuse with the diaphysis. So bone is no longer added on this end, for example. But bone is going on being added from the other end. So this slit becomes oblique. That's why.
Ma'am, how is it decided which end will be fused and stop growing?
You have to learn the ossification times for each bone. That is what you will do during the whole of first prof. You can't learn it in a 2-hour session today. Today we are just introducing all the terminology to you. And if you read, you should understand what those terms mean. Right? Okay? So these are some pictures which show you, this is a picture showing the growing bones in the hand. So these are the carpal bones, you can see. These are the metacarpal bones and these are the phalanges. So here you can see the primary centers have appeared. At the time of birth, all the primary centers have more or less appeared. Okay? Except for the carpus and the tarsus. The primary centers that ossify the carpal bones and the tarsal bones appear after birth. But the primary centers which ossify most of the other bones, all the other bones almost, appear before birth, roughly at 8 weeks of intrauterine life. The secondary centers which ossify the epiphyseal ends of long bones appear after birth, barring a few which are present in the lower limb. The lower end of femur, the secondary center appears at 9 months just before birth. This has a medico-legal significance. Now bone, I said, is a major site for hemopoiesis. It has red bone marrow in the marrow cavities. Now red bone marrow is present in all the marrow cavities and in all the compact and spongy bone at the time of birth. Now since I am using this term again and again, let me show you what compact and spongy bone looks like. Yeah, here. Yeah, you can see this is a section of one of the long bones. So this is what compact bone looks like macroscopically. I am sorry. This is what compact bone looks like. It is hard. It is dense. It is like ivory. And this is what spongy bone looks like. Now this is naked eye, macroscopically. they also have slightly different structure microscopically. But structurally, we can classify bones into two types, compact bone and spongy or cancellous bone. Can you see? So the spongy or cancellous bone, this is all spongy and cancellous bone. This is compact bone. Have you understood? So cancellous bone or spongy bone consists of bony trabeculae or spicules, which have marrow cavities between them. Now this is completely filled with red bone marrow. Now as far as compact bone is concerned, the shaft of a long bone initially has cancellous bone. Initially it has cancellous bone. At 7 years of age, the cancellous bone starts to recede from the shaft and then increases in volume and size at the ends. So the shaft which initially had cancellous bone now acquires a medullary cavity. And this medullary cavity, the marrow which was initially red bone marrow, gets replaced by fat cells and gets converted into yellow bone marrow. So that between 7 to 18 years of age, this process proceeds, and finally by 18 years of age, the red bone marrow is limited to the cancellous bone which is found at the ends of long bones, also found in the axial skeleton. Right? Whereas the shaft of long bones almost entirely have red bone marrow. Clear? I just introduced these terms because I am using these terms. So here you can see this is compact bone and this end will be cancellous bone, even in the forming bone. All newly formed bone is woven bone. The periosteal collar will lay down the compact bone. So bones are subject to remodeling, considerable degrees of remodeling, and the growth which occurs in long bones, in all bones in fact, is usually appositional growth, which means it proceeds either from the ends or the surfaces. Whereas in cartilage, the entire cartilage grows in size, and that is known as interstitial growth. So red bone marrow is red vascular, consists of a network of fine reticular fibers, and it has blood forming cells. Red bone marrow, which was present throughout the skeleton at the time of birth, after 18 years of age, is restricted to the ends of long bones, to the sternum and ribs, to the bones of the axial skeleton, notably the skull bones and the vertebrae. Now, where in the skull bones, you may ask? So, at the time of birth, these bones which are forming the cranial vault, these bones which are forming the cranial vault, these consists of only one thin layer of compact bone. But as they grow in size, cancellous bone splits this bone into two layers, forming an outer table and an inner table. Because bone is added from the external surface, it increases in thickness and is resorbed from the internal surface in order to accommodate the increasing size of the brain. Right? And the yellow bone marrow, which is rich in adipose tissue, is then restricted only to the marrow cavities or medullary cavities of long bones.
Ma'am, could you please repeat that one last which you told, resorption and
I'll repeat it. It will come again. Okay. Now, this is normally covered during the demonstration. Bones have several markings and bones have present several features. And for each bone one by one during a demonstration, we will see these bony features. So the bones will present polished and smooth surfaces where they are covered by cartilage and where tendons lie in grooves and where fleshy muscle fibers are attached. And the parts of the bones, like for example, if you can feel your shin, can you feel in your leg? There is a part where you can feel the bone directly. That is the shin. So the subcutaneous surfaces of the bone are smooth and polished. Rough areas are present wherever there is fibrous connective tissue attached, which means fasciae, ligaments, tendons, aponeurosis and intermuscular septae. Wherever all these are attached, the bones are rough. Bones also have several vascular markings which are created by presence of vessels and nerves and the entry points of vessels and nerves. So let's look at these pictures. So these are the various vascular foraminae which are present at the ends of long bones. And there is one large vascular foramen called the nutrient foramen, which is present roughly in the middle of the shaft. And as you can see, it is pointing in one direction. Can you see this? It is pointing in one direction. This is a picture of the nutrient foramen. Because in the lower limb, the nutrient foramen points away from the knee, so it is pointing upwards. It is here in the femur, close to this posterior border of femur, which is known as the linea aspera. So these are rough markings created by attachment of fibrous connective tissue. These are the vascular foramina. See this? Vascular foramina. And bones will tend to be smooth. They will have smooth facets wherever there are joints and where muscles, fleshy fibers of muscles are attached. Those parts of the bone will not have any rough markings. Okay? Now these markings can take the form of elevations, which can be linear, rounded or sharp, articular areas which are smooth and flat facets or expanded ends, depressions which may be small, large or long, and openings which have various names. Now what are those names? I'll just introduce. Now all this is done during the demonstration, but this time I have to take it up in the lecture itself. So the elevations can be linear. It can take the form of a line, it can take the form of a ridge, or it can take the form of a crest. Now examples of a line is the superior nuchal line in the skull. Example of a ridge is medial and lateral supracondylar ridges. Where are they present? I will show you. These are the medial and the lateral supracondylar ridges. Yeah, this is the medial supracondylar ridge. This is the lateral supracondylar ridge of the humerus. And likewise for the femur, medial and lateral supracondylar ridges. Lines, can you see this? This is a line. This is the intertrochanteric line. This is a trochanter, greater trochanter of the femur, lesser trochanter of the femur. These are rounded markings. Greater tubercle of the humerus, lesser is not visible because it is anteriorly placed, and this is a posterior view of the humerus. Okay? And on the posterior aspect of the femur is a sharp ridge which is known as linea aspera. Okay? So that is a line or a ridge. It can be in the form of a crest. For example, the iliac crest of the hip bone. Now let me show you the hip bone. Yeah. So this is the iliac crest of the hip bone. Can you see this? This is the iliac crest. Greater trochanter, lesser trochanter. Supracondylar ridges, medial, lateral. This is the lesser tubercle, greater tubercle. Head, rounded elevation. Head of the humerus, head of the femur. Intertrochanteric line. Okay. This is the anterior border of the tibia. You can see in the form of a line. Posterior aspect of the femur has a linea aspera, which gives attachment to muscles. Okay. So rounded elevations I've shown you. Tubercles at other sites as well. Another example of the tubercle would be, I'm sorry, on the hip bone. This is the pubic tubercle. This is pubic tubercle. Here, pubic tubercles. Yeah. Protuberance at the back of your head. If you can feel the back of your head, please do. There is a raised elevation in the center at the back, at the upper end of the neck, the back of the head. That is called as the external occipital protuberance. Tuberosity I've shown you, greater and lesser. Tubercles or tuberosities of the humerus. Malleoli. Malleoli are seen in relation to the ankle. Yeah. So this is the medial malleolus and this is the lateral malleolus. These are just names which are given, anatomical terms which are given to various types of bony features. Okay. So these are called as the malleoli. So on either side of the ankle you can palpate your malleoli. These are known as tuberosity or tubercle. They are also called greater tubercle, lesser tubercle, and they are also called tuberosities. For the femur, because they are larger, they are called trochanters. Greater trochanter, lesser trochanter. This is the pubic tubercle. Okay. Crest, another example between the pubic symphysis and the tubercle is the pubic crest. So you find this is the iliac crest. I'm sorry. This is the iliac crest. Then we will also find foramina. This is the obturator foramen, right? Notches, greater sciatic notch. No, I'm sorry, this is not the greater sciatic notch. This is the greater sciatic notch. Greater sciatic notches on either side. This is the suprascapular notch, like that. So these are names which are given to various bony markings. So wherever they are sharp, they are known as spine or process. So here we can have the spine of the vertebrae or of the ischium. I'll just show it to you. These are the spines of the vertebrae. This is the spinous process, spine of the vertebra. These are the transverse processes, transverse process. This is a view from above, this is a lateral view from the side. It takes a little while to get used to the terminology, it's all right. So spines of vertebrae, and where is the ischial spine? This is the ischial spine. So wherever it is pointed, these are known as spines, ischial spines. Process, This is coracoid process, rounded knuckle-like. Coracoid process. Styloid process you find at the lower end of the radius and of the ulna. Lower ends of the tibia and fibula are known have malleoli, raised prominent malleoli. Wherever it is rounded, they are known as heads. Head of the humerus, head of the femur. Expanded condyles. Tibial condyle, femoral condyle. This is the head of the radius. Okay. So, epicondyles are the summits of condyles and trochlea are pulley-like. So, if I have to demonstrate the epicondyles to you, going back to the diagram, yeah. So, this is the condyle, the pointed apices of the condyle on either end are known as epicondyles. So, this is the medial epicondyle, lateral epicondyle. Likewise, this is the medial epicondyle and this is the lateral epicondyle. This is the adductor tubercle. This is the adductor tubercle. The summit of the condyle medially and laterally. This is the medial epicondyle. This is the lateral epicondyle. This one. And this is a tubercle called adductor tubercle. Trochlea is present, is a pulley-like process is called a trochlea. For example, we see here a better diagram. This is pulley-like. This is called the trochlea. See this? This is called trochlea. Pulley-like. This is a depression. This is called a fossa, the olecranon fossa. So see, these are some of the bony. Now at the ends of the ribs, there are costal facets. At the head of the rib, which is posteriorly present, there are costal facets, and these facets are also present on the vertebral column. So where do we have the costal facets? Here. These are costal facets, because here the ribs are articulating. So on the head of the rib, which is present here, and on the sides of the vertebral bodies, and on the transverse process of thoracic vertebrae, costal facets are present. Costa means rib. So costal facets. At the anterior end of the ribs, where the costal cartilage articulates, also there are facets. So wherever there are articular surfaces, we will have flat, convex or concave depressions which are relatively smooth for articulation. Those are known as facets. Then depressions, I have mentioned some, but if they are small, they are known as fovea or pit. For example, the head of the femur has a small depression in the center, which is known as the fovea of the head of the or pit of the head of the femur. Where it is slightly larger, it is known as a fossa. I showed you the olecranon fossa. There is also the acetabular fossa, where the head of the femur goes in. I'll show you the acetabular fossa, where it articulates. So the depression in the side of the hip bone where the head of the femur articulates is known as the acetabular fossa. Similarly, a much shallower depression which is present on the lateral end of the scapula is known as the glenoid fossa or cavity, where the head of the humerus articulates. If it is long, it is known as a groove, also known as the sulcus. Examples of this is the bicipital or the intertubercular groove or sulcus at the upper end of the humerus. So let me show you the intertubercular groove or sulcus. So because it is between the greater tubercle and the lesser tubercle, this is known as the bicipital groove because it lodges the long head of the biceps, and it is also known as the intertubercular sulcus because it lies between the two tubercles. So a groove on the bone is known as a sulcus. Yeah, okay. These I cannot show you right now. With this you have to see in the cranial base a groove where the eustachian or the auditory tube is lodged, and this where the obturator nerve and vessels exit from the pelvis. This you will see on the hip bone. Notches are also known as incisura, and we find them greater and lesser sciatic notches in the hip bone. Now openings can be in the form of clefts or fissures. For example, the superior and inferior orbital fissures. I'll try to show you at least the superior orbital fissure in the skull. Yeah, no, it's not visible here. I'll need to show you the video for this. Just a minute. Yeah. So here you can see, let her pick up the skull. I can see the inferior orbital fissure here, although she has to lift up the skull to show you the superior orbital fissure. Let's see if we can see it in the skeleton. No. Anyway, we'll show you when you come back for classes. So they are present in the skull, superior orbital fissure, inferior orbital fissure. Yeah. Just a minute. I thought I saw one. No, can't see. But you can see the notch here. Can you see this? This is the notch on the maxilla. There is a supraorbital notch here. So these are notches. These are all bony markings. You will appreciate as you study individual bones. Okay. Then holes, apertures or holes are known as foramina. The singular is foramen and the plural is foramina. So we have in the cranial base foramen ovale, infraorbital foramen on the facial, on the front of the facial skeleton. Cranial base we also have foramen spinosum, rotundum, jugular foramen, foramen lacerum, foramen magnum. Foramen magnum is the hole through which the spinal cord exits the skull. The medulla becomes continuous with the spinal cord through the foramen magnum. Cylindrical markings are known as canals or meatuses. So external and internal acoustic meatus. Can show you the external and internal, not internal but the external acoustic meatus. Here. This is the external acoustic meatus on the side of the skull here. This is the external acoustic meatus. This is the external occipital protuberance that you can appreciate at the back of the skull if you palpate the back of your skull. Okay. Right. So we have talked about the various bony markings, and we have also mentioned that there is dense bone or compact bone which appears ivory like as a solid mass and makes up 75% by weight of the bony skeleton. It is thickest near the middle of the shaft, and this you can appreciate here. The compact bone is thickest here, but as you are going towards the ends, these are sections which are taken, transverse sections which are taken at the ends. You can see there is a gradual thinning of the compact bone. At the ends of adult long bones, the compact bone becomes a very thin layer, and most of it is cancellous bone. Whereas in the mid shaft of adult bones, the compact bone is thickest in the middle of the shaft. In the metaphysis also you will find some cancellous bone, and variably the medullary cavity extends into it, and this is what will appear at the two ends. Okay. Cancellous or spongy bone consists of a branching network of trabeculae which are arranged in such a way so as to act as struts, and they resist forces of both weight bearing, that is compression, and pull of muscles, that is tension. Now the essential structure of bone is that bone is laid down in layers, also known as lamellae, and these lamellae are parallel in cancellous bone, whereas they are concentric, forming Haversian systems in compact bone. The cancellous bone fills the interior of all bones except where it is replaced by medullary cavity, that is in the shaft of long bones, or by air sinuses, for example in the air cavities of pneumatic bones. And cancellous bone are thickest at the expanded ends. So compact bone is thickest in the middle of the shaft, whereas cancellous bone is thickest at the ends of the bones. Right? So compact bone, and this is cancellous bone. But there is an outer layer of compact bone still, even at the ends. Is it clear? Now, in the case of cancellous bone, the bony trabeculae, see these are bony trabeculae, you can appreciate these are bony. This is one bony trabecula. This is a scanning electron microscopic picture to show a bony trabecula, right? So these bony trabeculae are arranged in a pattern in order to withstand both the forces of compression as well as tension. So pressure lamellae are laid parallel to the line of weight bearing, whereas tension lamellae are laid perpendicular to the line of weight bearing. And this you can appreciate in an X-ray. So can you see, can you appreciate? These are passing across the joint in one line. These are weight bearing pressure lamellae. But also at right angles, so these are also weight bearing pressure lamellae. But also at right angles to these will be tension lamellae. And in addition to this, certain bones have bony buttresses that where the pressure lamellae are more compactly arranged and they provide additional support. So for example, the calcar femoral in the case of the femur has these lamellae. So this is the calcar femoral present in the femur. I'll just show it to you. It is present here. Here there is a more compact arrangement of the pressure lamellae to withstand the forces that are applied here. Now, a lamellus is the basic unit of bone tissue. What is a lamellus? It is a layer of calcified matrix that is laid down by bone forming cells and consists of bone cells, mature bone cells, which are known as osteocytes, that are trapped in lacunae between successive lamellae. So, compact bone has Haversian canals and Haversian systems, and it has Haversian lamellae which are concentrically arranged around the Haversian canals. Whereas cancellous bone will have parallel lamellae which are present within each bony trabecula or spicule. And the marrow cavities, which in the case of compact bone is essentially present in the medullary cavity, with which there is a communication through Folkman's canals and there is a communication with the Haversian canals. Here the marrow cavities are present between bony trabeculae. So this schematic diagram shows these various features properly. So this is cancellous bone. What you are looking at here, this is cancellous bone and this is compact bone, and the medullary cavity is here. Now compact bone consists of Haversian systems where the blood vessels and nerves are present within Haversian canals, which are surrounded by Haversian lamellae that are concentric, and these Haversian canals communicate with the medullary cavity and with each other through these Folkman's canals. They also communicate with the blood vessels and nerves of the periosteum. So here what you are looking at, these are osteocytes which are present in lacunae between lamellae. This is compact bone. In the cancellous bone also you have lamellae in mature bone, but these are parallelly arranged within each bony trabeculus, and the marrow is restricted to these numerous interconnecting marrow cavities. The periosteal blood vessels supply the outer 1/3 of the compact bone, whereas the nutrient artery, which has entered the medullary cavity, branched within the medullary cavity, sends branches into the inner 2/3 of the compact bone through Folkman's canals, and Haversian canals will supply to each Haversian system. So in a transverse section, they will appear concentric like this. There are also interstitial lamellae which communicate one Haversian system to another, and surrounding the entire bone both on the external surface and on the internal surface are circumferential lamellae present in compact bone. So this picture shows you a microscopic view of compact bone. These are the Haversian systems, Haversian canals in the center, surrounded by Haversian lamellae. This is a further magnified picture. These are concentric Haversian lamellae, the osteocytes present in lacunae, communicating with each other through fine canaliculi and also communicating with the Haversian canal. But if you take a longitudinal section of the bone, you will find these Folkman's canals. It's written with a V but pronounced with a F. Folkman's canals, like Volkswagen, which link individual Haversian canals and also link to the medullary cavity as well as to the surface of the bone. And thus, blood vessels and nerves and lymphatic vessels permeate the entire thickness of bone, even though it is so rigid. This is a highly magnified picture showing you bone cells which are known as osteocytes communicating with each other through processes which lie in canaliculi. So the osteocytes lie in lacunae. The lacunae communicate with each other through these canaliculi. The cell lies in the lacuna and its processes extend into the canaliculi. In the case of the cancellous bone, there are lamellae, but these lamellae are parallel within each trabeculus. And the blood vessels are present in these marrow cavities. And through canaliculi, because the thickness of each trabeculus is much less, through canaliculi they will enter and permeate the entire thickness of each bony trabeculus. This is what it looks like macroscopically, and this is in a stained section under the microscope. So from this we infer there are several types of cells. The mature bone cells are osteocytes, the bone forming cells are osteoblasts, and bone resorbing cells are osteoclasts. Osteoprogenitor cells are stem cells which give rise to all other varieties of cells that we find within the bone tissue. The outer fibrous covering of the bone is the periosteum, which has two layers. It has an outer fibrous layer which consists of dense collagenous white fibrous tissue, and an inner layer which is cellular, which has osteoprogenitor cells and osteoblasts, which give rise to bony lamellae. They lay down bone in layers, and some of these osteoblasts get trapped between layers in cavities known as lacunae and get mature into osteocytes. And present close to the endosteal lining, particularly the inner surface, inner table of the skull bones, the bone, wherever the bone is resorbed near the medullary cavity of long bones, are bone resorbing cells called osteoclasts. So all these are present in the periosteum and in the endosteum. Periosteum is on the outer surface, endosteum lines the inner surface of the medullary cavity and is also present in the marrow cavities of the cancellous bone. These are some of the functions of the periosteum. They provide protection, nutrition, growth, and periosteum in particular provides attachment to membranes, tendons, ligaments. Periosteum is anchored to the underlying bone through a thick layer of collagen fibers, which are known as Sharpey's fibers. And these fibers are absent where tendons and ligaments are attached to bones, and they are absent where the periosteum is absent. Now here I would like you to ask some questions before I discuss the blood supply of the long bone. Any clarifications of terminology, and then I will do the blood supply and stop.
Ma'am, can you explain the part you told about?
Yes?
You told about the canalically, that part which you
See,
explained.
this is histology, right? This is histology. This is when you study the bone under the microscope. Today I am just introducing these general anatomy terms to you. Canaliculi are tubular, tiny, microscopically visible tubular spaces which lodge the processes of the osteocytes. And through these, osteocytes communicate with each other. But what is more important for you right now are the Folkman's canals through which the Haversian systems communicate with the medullary cavity and with each other, and which you can see in longitudinal section. In transverse sections you can see mainly the Haversian canals. Here, sometimes a section may pass through a Folkman's canal.
Ossification law.
Pardon me? What?
Can you explain about ossification law?
Okay, the law of ossification. The law of, actually there are 4 laws of ossification, but the most important from your point of view. So the first law would state that the primary center ossifies the main part of the bone and appears before birth, but there are exceptions. Secondary centers appear after birth, but there are exceptions. The third law is what is most often quoted, the law of ossification, which states that the center which appears first fuses last, and that end of the long bone would be the growing end of the long bone, which is ossified by the ossification, secondary ossification center, which is the first to appear but the last to fuse. And the fibula, which is the lateral bone of the leg, violates the law of ossification, because here the center which fuses last does not appear first, and that is the lower end of fibula. So there are exceptions. Okay? So law of ossification, the one which you have to remember, states that the center which appears first fuses last. This is with reference to secondary centers of ossification, which have to fuse with the bone that is ossified from the primary center of ossification.
Is there any difference between tubercle and condyle?
Yes, condyles are flattened, tubercles are rounded. They are anteroposteriorly flattened. You wish me to elaborate further? I will show you. So this is the here. This is flattened from front to back. Condyles are flattened, whereas tubercles are rounded. This is also tubercle, and tuberosity can be used interchangeably. Anything else?
Ma'am, can a bone survive without periosteum?
There are bones which lack periosteum. So here the sesamoid bone does not have periosteum. A bone can survive, yes, but it cannot repair itself. So most bones if they are fractured, are capable of repairing themselves because of the presence of the periosteum. The cellular layer of the periosteum has osteoprogenitor and osteoblast cells which will form bony lamellae. But sesamoid bones are not real bones. These are formed in the tendons which are subject to friction, which rub across bony surfaces. These are bony nodules formed within tendons. So the largest sesamoid bone in the body is the patella. But there are others. So this will not have a periosteum. So it can survive. Of course it can survive. But if the patella is fractured, it will not be able to repair itself. If it causes discomfort, it has to be removed. If it doesn't cause discomfort, we just allow it to be left within the tendon.
Okay, ma'am. Thank you.
Any other question?
And what exactly is the meaning of trabeculae?
Trabeculus is actually a small bony plate. Cancellous bone is like a sponge work. So imagine you have a sponge. So there is a lattice work of solid material and there are intercommunicating cavities. So one trabeculus is one bony spicule. So interconnecting trabeculae form the spongy bone or cancellous bone.
Okay.
Any other clarifications? I will upload this. Bolo. Go on. Okay, malleoli are terms which are restricted to the ankle. Malleoli are terms which are restricted to the ankle. The singular is malleolus, the plural is malleoli. So medial malleolus, if you feel the medial side, you understand what is medial? Today you've been introduced to the terminology. Medial is what is closer to the median plane. Now you palpate or feel your ankle. Just feel your ankle. Can you feel a bony prominence on the medial aspect of your ankle? Can you feel it? Tell me.
Yes, ma'am.
That is the medial malleolus. And similarly, on the lateral aspect of your ankle, can you feel a prominence? Can you? That is the lateral malleolus. These terms are used only for the lower end of tibia and fibula in relation to the ankle. They are slightly elongated. Tubercles and tuberosities and trochanters are more rounded. Trochanters are larger. The smallest one is called tubercle. The medium sized one is called tuberosity. But tubercle and tuberosity for humerus is used interchangeably. And trochanter, because femur has larger ones, those are called trochanters. And malleoli are rounded, all right, but they are slightly elongated. And this term is used for the ankle only. Anything else? I will be showing you now the video and we'll do these terms again. I'm not stopping right now. We have yet to see, we have to do the blood supply and then you see the video and see what all you can see in the video. Because that will give you a feel of the real bones. It's not exactly the same as seeing the real bones, but this is the only substitute we can find at the moment under these circumstances.
Ma'am, Sharpie's fibers.
Sharpey's fibers are collagen fibers which anchor the periosteum to the organic framework of the bone. They are absent only over the articular surfaces because there the periosteum is also absent. The periosteum is not present over the Articular surfaces. You understand what is articular surface? Articular surface is that part of the bone which forms a joint with another bone. That surface is smooth and is covered by articular cartilage, and this articular cartilage is, which covers the end, the joint forming ends of bones, also lacks a perichondrium. The perichondrium is the outer layer of cartilage.
But actually those are the extensions of tendons, right?
No. Sharpes fibers are connective tissue which anchor the periosteum to the underlying bone. Tendons and ligaments are also become continuous with the organic framework of the underlying bone. But Sharpes fibers are present throughout the periosteum. Whatever your earlier books may have told you. Sharpes fibers are collagen fibers which anchor the periosteum to the underlying bone, including those at the where the ligaments and tendons are inserted. There they are more thick and prominent. That's all.
Okay, ma'am, thank you.
Any more questions? Should I show you the video first and then do the blood supply, so that you can look at some of the bones and examples that you have studied today? You want to see the video first? Yeah. So I'll explain alongside. There's no audio in the video. I'll be doing the explanation. Okay. So here we are looking at different types of bones. What bone is this? Anybody? What bone is this? It's an example of a long bone.
Humerus.
Yeah, it's humerus. This is what type of bone according to, based on shape, what classification? It is a long bone. Once again, long bone. So you can see it has a shaft or a body and it has two ends. Now these are the carpals. They are arranged in 2 rows of 4 bones each. Carpals. These are examples of short bones. These are examples of short bones, carpal bones. Okay? Once again, what are these? This one, this one, this one, this one and this one. What are these? Metacarpals. These are examples of, very good, miniature long bones. What are these? These 2 and these 3? Phalanges. These are also examples of, what type of bones are these? Miniature long bones. Excellent. Very good. What is this? This is a vertebra. And what is this one? This is a hip bone. No, this is not scapula. This is hip bone. This is hip bone. You can see this. This is the acetabular fossa. This deep cavity you will not find in scapula. This is the hip bone. It consists of 3 parts. Ilium. I'm sorry. So this is the flared out upper part is the ilium. This part is the ischium and this is the pubis. And you can see this is the acetabular fossa into which will fit the head of the femur. Okay? Now in this picture, because he is turning it around, I can show you this is the pubic tubercle. You see this? This is the anterior superior iliac spine, posterior superior iliac spine, greater sciatic notch, obturator foramen, vascular foramina of vessels. You can see here also. You see these vascular foramina. This is the scapula. This is the scapula. The scapula has a flattened, this is an example of flat bone. This is an example of, once again, I'm sorry. Yeah, flat bone. I'll pause the video. This is an example of a flat bone. Okay? So here, this is a process. This is known as coracoid process. Okay? Now let's turn it around. This is the spinous process of the scapula. And let's go back a little. This part is called the acromion process. So this is acromion, this is spinous, and if we go back further, this is the coracoid process. This is the glenoid fossa, which lodges the head of the humerus to form the shoulder joint. Fine. And in the scapula, we also saw notches. We can also see some notches. This is the suprascapular notch. This is the spinoglenoid notch, because it's between the spinous process. Now this is an example of a pneumatic bone, because it has, this is the maxilla, because it has an air cavity, the maxillary air sinus. The maxillary air sinus. Can you see this? So in skull bones, several skull bones, the frontal bone has frontal air sinus, ethmoid bone has several air sinuses, the maxillary bone has the largest maxillary air sinus, and the mastoid part of the temporal bone has mastoid air cells. Okay? Then the sphenoid bone has sphenoid air sinuses, a pair of them. These are present because they are present on either side of the nasal cavities. They are formed by the extension of the nasal mucosa into the spongy bone, the cancellous bone of bones that form the skull. So these bones, which in place of marrow cavities develop air sinuses, these type of bones are called pneumatic bones, spelt with a P, pneumatic. Clear? And this, several functions have been ascribed to why these air sinuses are present. We don't know for sure, but it lightens the skull. It also humidifies the air. It also adds resonance to the voice. So these are various functions which are ascribed to, but the disadvantage of these sinuses is they are likely to be subject to the same infective agents which inflame the nasal mucosa, leading to a condition which is known as sinusitis. So maxillary sinusitis, frontal sinusitis, some of you may have experienced. Whenever you have a cold, you also side by side get sinusitis. So this is a pneumatic, this is an example of a pneumatic bone. Okay. This is the patella, the kneecap. This is a bony nodule which is present within the tendon of a muscle. It is present here. This is a patella on either side. So this, the variety of bone it is a sesamoid bone. What type of bone is this? Sternum. What type of bone is this? Tell me. Flat bone. Correct. Flat bone. Excellent. What type of bone is the rib? Flat bone. Correct. What type of bone is the vertebrae? Are the vertebrae? Vertebra for singular? Irregular bone. This is the hip bone. This is again irregular bone. Okay. So this is just to show you the whole skeleton, to place all. So this is the olecranon fossa, where the olecranon process of the ulna is lodging. Spinous process of scapula. This is clavicle on either side. This is in front. Scapula is at the back. The ribs, vertebral column, iliac crest also we saw. Obturator foramen, ischium. Okay. Now one more video. This has the same thing, but it also has parts of the skull. Glenoid fossa, spinous process, acromion process, again hip bone, vertebra, pubic tubercle, acetabular fossa, maxilla with the air sinus. This is the maxillary air sinus. So a pneumatic bone, sesamoid bone, patella, seed-like, present in the tendon of quadriceps femoris. Now here we have skull. So these skull bones, the frontal bone is an example of flat bone. Parietal bone is flat, entirely flat. Frontal has some parts which are not flat. This is the parietal bone. This is entirely flat. Now these are supernumerary bones or accessory bones, sutural or vermian bones. These are various terms which are used for these bones, which are present because there are extra ossification centers, and if this part of the bone does not unite with the main part of the bone, giving rise to, in certain individuals only, these vermian or sutural bones. Not present in all skulls. Can you see these? These are sutural or vermian. Now this is a long bone. I'll pause this video. So here you can see the medullary cavity. This is the femur, a longitudinal section through the femur to show the structure of the femur. So there is compact bone. You can see the compact bone here. Compact bone. But as you go towards the end, the compact bone becomes a thin shell. Here you find cancellous bone. And here you find the medullary cavity. Again lower down, it is cancellous bone. This is calcar femoral, a bony buttress formed by a compact arrangement of cancellous bone, present here. Longitudinal section through the bone. Greater trochanter, lesser trochanter. This is cancellous bone. And here we have the medullary cavity. Again cancellous bone. Fine? So I hope you had some idea of the what it looks like in real life. I was severely handicapped. I was not able to explain much because the demonstration has not yet happened. We try to make it up through this in this manner, but of course there is no replacing physical classes. So now to continue, somebody asked what exactly is a trabeculus. So this is a trabeculus. These are trabeculae. Okay, bony plates. Now we do the blood supply of a long bone. So the long bone is supplied mainly through a nutrient artery which enters the medullary cavity of the long bone through a nutrient foramen. And this nutrient artery divides into branches within the medullary cavity, and these branches then enter into the compact bone. You can see here, this is compact bone, through the Folkman's canals, and then communicate into the Haversian, communicate the blood vessels into the Haversian canals. Blood vessels, lymphatic vessels and nerves will enter the Haversian canals, and the supply will pass to the bony lamellae surrounding each canal through the canaliculi to each cell. So the inner 2/3 of the compact bone is supplied by blood vessels, which are branches of the nutrient vessels. The periosteum is also is a highly vascular membrane. It has a very rich blood supply. And the outer 1/3 of the bony cortex or the compact bone is supplied by branches which are entering its substance from the periosteal arteries. There are also arteries that supply joints, and they will give branches to the metaphyses and the epiphyses. So these are the various types of arteries and the veins with the same name that supply a long bone. So a long bone has such a rich and extensive supply that necrosis is fairly rare. And that is why we can even put pins. Surgeons can put pins within the medullary cavity if the bone the fracture has to be reduced, and the bone has to be placed in proper alignment, in a compound fracture, in proper alignment, and so that the new bone which is formed is like the unfractured, the previous, the normally present bone. This will not interfere with the blood supply. Now the blood vessels which are present in the metaphyses, as long as the epiphyseal plate of cartilage is still present, do not communicate, do not form anastomosis with the blood vessels which are present in the epiphyses, and they end blindly. So infective foci can lodge here in the metaphyses, leading to osteomyelitis in children. Whereas in adults, extensive anastomosis is established between the metaphyseal and the epiphyseal blood vessels, and therefore osteomyelitis is not common in adults after the fusion of the epiphysis to the diaphysis. Now cartilage will again do in histology, but I'll just introduce you to the three main types of cartilage: hyaline cartilage, elastic cartilage and fibrocartilage, because in the next class you will need to know the three varieties of cartilage. So most of the cartilage in the body is hyaline, which includes the epiphyseal cartilage. It includes all the embryonic bones are preformed in cartilage models. Those are also hyaline. The costal cartilages, most of the cartilages of the larynx and of the tracheobronchial tree as well as of the nose, barring some exceptions. The cartilage of the pinna, the external ear or auricle, is elastic cartilage, and some laryngeal cartilages, epiglottis, corniculate and cuneiform. And the cartilage which forms the cartilaginous part of the auditory or eustachian tube is elastic cartilage. Fibrocartilage is present in intervertebral disc. It is present in intra-articular discs, glenoidal and acetabular labra, in the menisci of the knee joint, and certain articular cartilages. Now the essential difference, macroscopic difference between these three varieties is hyaline cartilage is very homogeneous and appears bluish. Elastic cartilage, because it is rich in elastic fibers, yellow elastic fibers, is very flexible, and fibrocartilage is very rigid. Of these varieties, perichondrium is present in hyaline and elastic cartilage but absent in fibrocartilage. Wherever tendons play on bony surfaces, the grooves are lined by fibrocartilage. Wherever flexibility is required, elastic cartilage is present. Most of the cartilages in the body are hyaline cartilages, including the articular cartilage, which is a special variety of hyaline cartilage that lacks a perichondrium. So these microscopic pictures you will do later, but this is what hyaline cartilage looks like. Embryonic cartilage, which is also hyaline. Elastic cartilage has a number of elastic fibers. Articular cartilage is a variety of hyaline cartilage which lacks a perichondrium. That's it for today. Any clarifications?
Ma'am, ma'am, in that cartilage, you said something about menisci, labra, and articular cartilage.
Okay.
I didn't understand.
Okay, you won't understand till you do the part. But anyway, since you've asked, labra, glenoidal labrum and acetabular labrum are present along the periphery of the glenoid cavity of the scapula, and the acetabular fossa, they tend to deepen these cavities and they improve the articulation of the humerus with the scapula at the shoulder joint and of the head of the femur with the hip bone at the hip joint. Menisci are fibrocartilages which are present within the knee joint. Articular cartilages are present in certain joints like the sternoclavicular joint will have articular cartilages.
Okay, ma'am.
Any other questions? Any other clarifications of terms? Anybody else would like to ask questions? So, yeah, ask please.
A facet can be both concave and convex.
Yes, facet can be plane, can be concave or convex.
Okay.
You want examples? The articular facet at the upper end of the humerus is convex. Okay. Whereas the articular cartilage which lines the glenoid cavity and which lines the acetabular fossa is concave. Acetabular, so costal facets at the anterior end will be concave, and costal facets for the head of the rib are convex. In the vertebrae, on the sides of the vertebrae, they are usually plane or slightly concave.
Okay.
Any other questions? Any clarifications at all? Because I know it is very tough understanding it without seeing the real bones. And it is difficult for me. I was severely handicapped. I didn't know which term to introduce and which term, which is why I went a little haltingly. Normally, you've seen it all. You people see it all in the dissection hall, and then we can assume certain things, right? Any other clarifications? Please ask.
Right now, how would you recommend us to study all of these terms then?
Read the first 19 pages of the volume 1 of Cunningham's Manual of Practical Anatomy.
Okay.
The Cunningham's Manual has 3 volumes. The first one you have to purchase. Another textbook which we recommend is Regional Anatomy by Snell. So Snell's Anatomy, that's another book we recommend, where also you can understand these terms. Any term you don't understand, please ask right now. I am open to questions. Any term which you haven't understood so far, which has confused you. Because right now, more important than understanding how bones are ossified is to understand the language of medicine. Anatomy introduces you to a whole new set of terms, and you have to learn to use those terms in regular language, isn't it? So it's a whole new language.
Could you explain aponeurosis?
Aponeurosis are flattened tendons. So mostly tendons of muscles are in the form of solid cord-like structures. But for example, the abdominal muscles, they are flat. There are muscles in the anterior abdominal wall, they are flat. If they have to insert, they will insert through flattened tendons. And those flattened tendons are called aponeurosis. Any other term?
Interstitial growth and appositional growth of bones.
Cartilages grow as a whole. I didn't want to introduce too much today, but since you've asked, I'll tell you. What is the structure of cartilage? I haven't talked about the structure of cartilage. So you see, these are the cartilage cells. They are called chondrocytes. They lie in lacunae. And these chondrocytes, they produce the extracellular matrix. They produce the fibers. And so the cartilage grows as a whole. Throughout the substance of the cartilage, it will grow. In the case of bones, the growth is taking place at surfaces or ends. Okay, so if you look at the structure of the bone, on the other hand, you can see the screen, right? You are able to see the picture on the screen. Yeah. So if you look at the structure of the bone, on the other hand, yeah. So here the growth takes place from the periosteum or at the level of the endosteum, or Haversian lamellae are laid down around the Haversian canals. Okay. And in spongy bone, the growth is going to take place at the level of the marrow cavities. It will lay down lamellae. So appositional growth means it is taking place. So for long bones, there is an increase in the thickness of the shaft of the long bone, the diameter of the long bone, and also there is a growth at the ends. There is an increase in the length of the long bone. But what about flat bones? How do they grow? The flat bones which form the cranial vault also have to grow. So they grow, more bone is laid down on the external surface and resorbed from the internal surface by osteoclasts. Laid down by osteoblasts, resorbed by osteoclasts. So that the cranial cavity also expands. It has to accommodate the growth of the brain, isn't it? So appositional growth does not permeate the entire substance of the tissue, whereas interstitial growth permeates the entire substance of the tissue. That is the difference. Any other question? Does this satisfy you? It won't satisfy you completely till the depth of your knowledge gradually increases as you read. This will happen gradually. It's not going to happen today. That's for sure. Today you'll just get the hang of some terms. That's how everyone learns. All of us have learned that way. It's fine. It's fine if you don't understand everything today. But the terminology, try to get the hang of the terminology. Yeah. Any other question? Any other question?
Ma'am, will you be emailing this PPT to
No,
us?
no, not emailing. This will be uploaded on the Saral platform. Did Dr. Sharif introduce the fact that you can access online through the Saral platform?
Yes, ma'am, but till now none of them have.
No, I didn't do it initially because it would have overawed you too much. So I wanted you to hear the lecture first and then I will upload. I will do it today. And that will have the lecture content of not only this lecture but also tomorrow's lecture. I will do it just now.
Okay, thank you.
Any other clarifications? Should I stop? There are some comments on the chat box also. No comments. We can't do it individually. It will be uploaded on the website and then you can access from there. Can I stop?
Ma'am, on the website, will the PPT be available or the lecture?
Both, I think. I will upload the PPT. I will upload the videos.
Yes, ma'am.
But because this has gone through YouTube, I think even the lecture will be uploaded. That the academic section has to do. So where there is resource material for every class, there I will upload the PPT.
Ma'am, the last type of epiphysis, please.
Okay. So there are pressure epiphysis, traction epiphysis, atavistic epiphysis and aberrant epiphysis. Aberrant is the last type. Aberrant are not always present. They are extra epiphyses present in certain bones of only certain individuals. Not all. You want examples? Talus is one of the tarsal bones that may have aberrant epiphysis. So the os trigonum. Sometimes some metacarpals, metatarsals have aberrant epiphyses. Aberrant epiphyses may also be present particularly at the lower end of the fifth metatarsal. That is called os vesalianum. So whenever aberrant epiphyses are present, if they fuse with the main part of the bone, fine. If they don't, they may appear as extra bones. And these are known as accessory or supernumerary bones. When they are present in the skull sutures, in the sutures of skulls, you understand what are sutures? Sutures are the joints between skull bones. So then these supernumerary or accessory bones are known as sutural bones. Okay? Also known as Vermean bones. Example of atavistic epiphysis is coracoid process. Example of pressure epiphysis are the weight bearing epiphyses of the limb bones, including head of humerus, head of femur, condyles of humerus and femur, upper end of tibia, tibial condyle, lower end of tibia, not the malleolus, that is traction. Malleoli are created by pull of tendons. Whenever the periosteum is pulled, by tendons, there is a stimulation of bone growth, and so these bony prominences are created. That is why in very young bones, in very young people, bony prominences are not very obvious. But as you grow older, especially in athletes where there is a lot of muscular activity, the tubercles, ridges, trochanters, malleoli become more prominent. Any other question?
Why it's called atavistic? Atavism means reappearance of ancestral characters.
Actually, in lower animals, these remain as separate bones. The pectoral girdle, I don't know exactly how many. You have studied zoology, you tell me. But the other, the primates other than humans have more than 2 bones in the pectoral girdle. Isn't it true? Coracoid process is phylogenetically a separate bone, which in humans has fused to a nearby big bone, that is scapula. So now, because it has formed a small part of scapula, it is an epiphysis, because by definition, epiphysis is the part of the bone which ossifies from a secondary center of ossification. And a secondary center of ossification is one which forms a small part of the bone, usually near an end. Primary center of ossification forms the main, principal, M-A-I-N, main or principal part of the bone, like the shaft of long bones. But in flat and irregular bones, most of the bone is formed by the primary center of ossification. The smaller parts of the bone are ossified by secondary centers of ossification. So, in growing bones, that part which ossifies from primary center is called diaphysis, and that part which ossifies from secondary center is called epiphysis. And because it is called epiphysis, but it was initially phylogenetically a separate bone, so it is called atavistic epiphysis. By definition, atavistic.
Ma'am, the chondrocytes of the cartilage themselves release the collagenous fibers and the matrix.
They form the entire cartilage, yes. They lay down the... So
bone
may be... No. Bone may be osteocytes are going to... Growth will take place. Osteoblasts lay down most of the fibers and the lamellae. Osteocytes, the mature bone cells. Osteoblasts. The cartilage also has... Huh?
Osteocytes do not release the matrix and fibers.
Not in mature bone, no. That is why surfaces is where the growth will take place in the bone. Whereas in the case of cartilage, chondrocytes are producing the extracellular matrix, which includes the fibers and the ground substance.
Yes, ma'am.
Okay? Should I stop now?
Ma'am, can you give us your email ID?
Pardon me?
Ma'am, can you give us your email ID?
I am going to upload it. Why do you need my email ID? And there is a... If you have any questions, there is a undergraduate WhatsApp group. You can post your questions. I will answer you. Okay? And you can even in the chat boxes ask questions. You can ask away. In fact, I normally take very interactive lectures. And right now today, I can't see anybody. And I don't know if you can see me. So it is very difficult to take this lecture, this type of lecture. I find it particularly with no baseline, demonstrations. But anyway, we'll try to make the best of it, however possible. Anything else? I will answer all your questions. Pardon me?
And metaphysis is formed from the primary ossification part.
Absolutely. Correct. You've got it. Metaphysis is nothing but the flared out epiphyseal end of the diaphysis. And by definition, what is diaphysis? That part of the bone ossified by primary center. but metaphysis has a different structure compared to the rest of the shaft, so it is qualified by a separate name. That's all. Okay, that's it.
Ma'am, does the interior of metaphysis have a spongy bone?
Pardon me? Yes, it does. Yes. Structurally, diaphysis, this is another difference between metaphysis and the rest of the diaphysis. It has cancellous bone. That's right. Anything else? Should I stop? Can I stop?
And what is bone collar made up of?
Actually, what happens is, this I didn't introduce because I thought it would be too much. All newly formed bone is woven bone. Whether compact, whether coming from the primary center of ossification or secondary center of ossification. Woven bone, compact bone is the densest. Cancellous bone is less dense. The least dense form is woven bone. So whether it is of the shaft or of the ends, newly formed bone is woven bone. Then later, during intrauterine life, what happens is, the periosteum starts to lay down a dense, relatively dense compact bone, and that is what is known as the periosteal collar. So if I show you this here, this is what woven bone looks like. This is what woven bone looks like. It is even less dense compared to the, and it doesn't have lamellar structure. Now cancellous bone, even though is a fine lattice work of bony lamellae with marrow cavities, but within each trabeculus there are parallel arrangement of lamellae. Whereas the woven bone has a random arrangement of collagen fascicles and bone crystals, forming a network. So it's only when compact bone is laid down by the periosteum around the middle part of the bone in the form of a periosteal collar that the shaft acquires compact bone. Initially, even that is cancellous bone. It's not cancellous, it is woven bone. Now, where the organization is better defined, that bone is called lamellar bone. And lamellar bone is of two types. One is compact and one is cancellous. Where it is in the form of concentric cylindrical Haversian units, it is called compact bone, and where it is in the form of anastomosing curved trabeculae, it is called spongy bone. Any other questions? Somebody said something, but I didn't catch it. Anything else?
No, ma'am.
So I'll stop. I'll stop the meeting.
Yes, ma'am. Yes, ma'am. You should stop.
Everyone is satisfied? I hope. Okay.
Yeah.
Great.
No more doubt.
Any other doubt if you remember later, because you will keep having doubts. If you are questioning, that means you are trying to learn.
No,
This is a
ma'am,
good sign.
No more doubts we have.
This is a good sign. So questions are always welcome. Okay? So I am ending the meeting now. Thank you.
Thank you, ma'am.
Bye, ma'am. Thank you, ma'am. Thank you,
Bye.
ma'am.
This conference
Thank
is
you,
no
ma'am.
longer being recorded.
Thank you, ma'am.
Okay.
Thank you, ma'am.
You're
Thank
most
you, ma'am.
welcome. You're most welcome. I would have liked to see the bright young faces of the students, but I was deprived, and I would have liked to introduce myself to you, but we are deprived of that. It's on hold right now. Okay.
Thank you, ma'am.
Okay.
Thank you, ma'am.
ओह, अभी ये इधर ही है लेक्चर, इसको डिलीट करोगे आप?
हाँ जी, हाँ जी।
क्योंकि ना अभी नए नए हैं ना, नॉर्मली डीएच में क्लैरिफिकेशंस होती हैं, अभी कोई डीएच हो ही नहीं पा रहा, इनको पढ़ाना भी मुश्किल हो रहा था।